Álvaro, buenos días.
Hoy estamos igual, Sala está Felipe. En el B, ¿cómo se llama? Y hoy hay Salón C.
¿Quién está en el salón B?
Tatiana.
Tatiana.
Bueno, todos empezamos con el Salón A, ¿cierto? Y en este momento, ¿hay algunos de los muchachos con los que podamos entrar? ¿En el A o en el B? No, mira que yo estoy esperando en el A y en el B y no. Ok.
5 de la mañana, Mosco. 4 de la mañana.
¿Descansó usted o no? Doctores, gusto verlo.
Mi Mosco, ¿cómo estás?
Bien. Gracias.
¿Quién está hoy en el salón B? ¿Tatiana? ¿Quién es la persona que nos va a ayudar?
Tenemos un lomo de res, bañado en salsandino, bañado en ensalada de pasta y de puré. Tenemos chorizo, baby beef, churrasco. No, es el que vieron ustedes. El lomo de res. ¿El lomo y chorizo? ¿Cuál? El lomo de res de nuestra tierra y la señora un beef chorizo. La señora, ¿ustedes qué vieron acá?
Como dirían las niñas de antes.
¿Usted qué me recomienda?
Señorita.
Dame ese con el puré.
¿Lomo de res?
Con el puré.
Solo puré.
El puré, el lomo de res sandino y el otro.
Ensalada de palta.
¿Ensalada de qué?
De palta.
Quedó súper.
Hola.
Hola Fabio, ¿ahí me oyes?
Sí, claro.
Sí, te oigo. Te oigo.
Chala va a hablar.
Niños, hablen más bajito, hablen más bajito.
Estoy tratando que me ayudes con la parte del fondo virtual.
Fabio,
Entonces,
te paras donde dice
De la rota.
parar
Aquí.
video y ahí te aparece una flechita y ahí
Sí.
le das elegir un fondo virtual.
entonces aquí dice fondo virtual. Entonces elegir un fondo virtual más. Entonces,
Y
pongo más,
ahí
¿cierto?
le das en el más y en el más te dirige al sitio donde tú hayas guardado la plantilla.
Ok, ya la guardé y ahora acabo de abrirla.
A las 7.
El ordenador para usar un fondo virtual sin pantalla verde. Ser 10, 13, por favor, un Intel por 5, 4, prepare una pantalla verde. No sea bruto.
Hay unos computadores que no tienen la aplicación toda y entonces el fondo de pantalla no deja ver eso. No sé si tu computador lo deje hacer.
Entonces espérate a
Dale
ver.
ahí como si tuvieras una pantalla verde y le das a aceptar a ver si te deja.
Entonces espérate.
No, Fabio, ¿qué pinta?
Como si uno tuviera una pantalla verde.
Sí, es que le sale la misma opción que a mí y no deja.
No deja que.
Puede ser que no tengas actualizado el Zoom. Si ves cómo salgo
No,
yo,
pero tú también
en mi
sales
computador no me deja. Entonces yo no he podido ponerle, ahí tú sí ya pudiste.
Ya pude. Hay que tengo una pantalla verde reflejar mi video.
No toca ninguno porque no me deja.
Ya,
Ahí ya
entonces,
estás, perfecto, así es. Entonces,
así
cuando
es.
vayas a entrar hoy, acuérdate que entras 10 minutos antes al salón B. Haces de una vez esto.
O sea, tú me estás viendo ya con el fondo,
¿Ya?
¿cierto?
Perfecto. Sí, se ve súper bien.
Ok, gracias, Pablo. Bien, todo perfecto. Aquí les tengo unas preguntitas. Pablo, ¿me estás oyendo?
Sí.
Perfecto.
Les tengo unas preguntitas a todos, a cada uno, pues, para disfrutar, para que cada uno dé su opinión. Muy específicas con el balón, porque son procedimientos especiales, indudablemente, especiales, pero hay que exprimirlo porque, a ver, tenemos el inventor del asunto, tenemos el que diseñó el procedimiento de la reconstrucción capsular superior, tenemos la persona que más experiencia tiene con la referencia de la super reconstrucción con la matriz de órbita celular, es decir, vamos a sacarle jugo al asunto. Perfecto. Entonces, pero ustedes
El
están
Mosco
viendo.
dice que Pocho es el que tiene más experiencia en el mundo, entonces que si lo conoce.
No. Sí, claro. No, Pocho tiene la mayor experiencia en el mundo en todo. En todo, pues. Eso sin nada que hacer. Bueno, oiga, gracias. ¿Dónde están reunidos? ¿Dónde están reunidos?
En el hotel ¿cómo se llama este? Hotel Dan Carton. Dan Carton, en la 15.
Me quedan debiendo los Martínez.
Fabio,
Uy, sí, ese nos toca.
Fabio, es muy importante poner a discutir ahí por qué hacer bíceps y
Sí, tal
hacer
cual.
plata, weón.
Sí.
Hazme esa
Por
preguntita a
supuesto.
mí para sacarme ese clavo.
No, claro, no, le voy a decir, no crea que te tengo reservadas algunas, no te preocupes.
Fabio, algo muy importante para todos, algo muy importante para todos. Las preguntas hay que hacerlas en español.
Yo por eso
Ok.
les estoy escribiendo a los moderadores que nos conectemos a la 1:05 que vamos a dar unos
Para que
tips.
todo el mundo utilice el traductor. Es mucho más fácil.
Bueno.
Cuando empezamos en inglés y en español y no sé qué, eso es un lío. Para que los conferencistas se metan a su canal de traducción, para que ellos les lleguen las preguntas
Entonces,
en español.
dile a tus conferencistas que en la plataforma de Zoom, en la parte de interpretación, ellos pueden escoger el idioma que van a escuchar, que como vamos a hacer toda la discusión en español, ellos deben cambiar en su plataforma de Zoom el audio para que ellos escuchen bien.
La explicación para todos de una vez, aquí también. No,
Okay,
esto funciona de la siguiente forma, Fabio.
Dilo.
Apagado, no hay traducción.
Sí.
En inglés hay traducción, Mecho. Si está apagado, solo se oye al conferencista en el idioma que esté hablando. No, español no funciona.
Ajá.
Y cuando eso se hizo para los conferencistas, es cuando está en inglés, traduce al otro idioma. Que para los conferencistas no tiene problema, porque ellos si estamos hablando en español y ponen inglés, pues se oyen en inglés. Para nosotros, si están hablando en inglés y uno pone inglés, sale español. ¿Sí me entienden?
Okay.
Es como si fuera apagado o prendido.
Por eso,
Si fuera apagado o
es un
prendido.
solo canal,
Sí.
apagado, prendido.
Apagado o prendido. Apagado o inglés prendido. ¿Listo?
Ok. Les voy a escribir ya al chat que tenemos en conjunto, precisamente para aclarar.
la traducción.
Que utilicen la traducción para el momento de discusión. La presentación, voy a dar 2 minutos de presentación antes de inicio del bloque porque la tengo ahí preparada, ¿ok? Denme 2 minutos.
No, tómate unos par de minutos para hacer tu presentación.
Sí.
Quiero agradecerte, Fabio, porque quizás has sido la persona que más en serio se ha tomado esto de la coordinación. Muy bueno lo del chat, muy bueno lo de pedir las hojas de vida. O sea, muy bien, Fabio. Felicidades.
Bueno, con mucho gusto.
Falta el corbatín.
Podemos proponerlo para
En el espinal.
Pero que no sea el de Sebastián, por favor.
Fabio, podemos proponerle a usted para que sea presidente de ACCART algún día.
Ok. Bueno, bye.
Venga.
Me encantó. Chao. Cuídense. ¿Ah? ¿Qué pasó? Sí. No, pues, está ahí. Sí. Mira, no sale nada. Salir de la reunión. Ellos están ahí. Pero mira que ya me salió. ¿Sí viste que salí yo? ¿Sí? ¿Cómo salí? Claro, pues puta. A ver, ya me...
Pero lo que tienes que hacer es no tan alto, hay que dejarlo así para que se te vea el cuerpo, no la
Sí,
pura cabeza.
sí, entiendo.
O sea,
entiendo.
no,
Es muy importante, Fabio, que siempre tengas
Sí.
el micrófono en mute, porque si no, todo lo que está a tu alrededor va a aparecer, ¿ok?
Ok. Perfecto. No problem.
así está perfecta
No.
la altura.
Sí. Listo. Chao.
Hey, my friend, how are you?
No, pero es que no puedes hablar porque en este momento está César en su charla. No lo interrumpas.
No. Ok, no importa, están conectados, pero no están.
Yo estoy en la sala B.
Sí.
Es que a que les hablan a...
Ah, ok. No, esa charla se transmitirá por la sala A.
Ah, yo no puedes hablar.
¿Dónde están?
Pascal, could you open your micro just to be sure that everything is okay?
Estás en el Zoom de la sala B.
Sí.
En el Zoom.
Sí. No se está oyendo allá nada de lo que estoy diciendo acá, ¿no?
No. Pensé que estabas como participante. No, estás en
No, estoy
Zoom.
en el Zoom. How are you, Pascal? How everything?
Explíquele la traducción.
Que la discusión se va a hacer en español.
Pascal, can you hear me? Dile por favor a Néstor que se conecte y que se conecten los demás conferencistas, por favor, ¿ok?
That's good. Can you hear me?
Yes, perfect, Pascal. How are you, my friend?
I'm good, and you? How is the meeting?
Very well, very well. It's a huge challenge. I can't imagine about you in your meeting. It's amazing the work behind that. It's amazing.
It's a big work.
Yes, it's a big work. But we start yesterday. Very nice. We don't have technical problem. This is my main fear about this kind of meeting. Most of the surgeons are pre-recording the talks, but you are in live. For me, it's better because it's better for me hear you in live. Okay.
Yeah, I'm just looking for my okay. For my talk.
Could you share just to be sure that everything is okay?
No, I think everything is okay. I want to make sure that I will be able to share my screen with you.
Okay.
But I think it's okay. It's okay now. The first talk is on instability and massive cuff tear, is it?
Yes.
Okay. And the second talk on...
and the second talk is...
Lateral.
With letter J, yes.
Hola, buenas tardes. Hello, nice to meet you.
Nestor, let me introduce Pascal. Dr. Nestor, he's our coordinators in this symposium. Nestor is a very, very good shoulder surgeon in Bogota, Colombia. So,
you're kind.
Nestor.
I know him. I'm sorry.
You at Nice and sorry.
I don't have the tie. I'm sorry.
I can remove it. It's simplest. The president, Dr. Inas, asked me to wear a tie, so I need to do it. He's the boss.
Pascal, just two concerns, 2 points. Number one,
Hi, Pascal.
Moscow wants to say hello, Pascal.
I met you 10 years when you were in Cartagena, Pascal. Nice to see you.
I remember you. I remember
Thank you. Thank you.
You're welcome.
The talk is in English, of course,
Yes.
but the discussion is in Spanish because more of our attendance is Hispanoparlant. So you can put it in the low of the part of your screen, interpretation, and you put English on in the moment of the discussion, because Nestor and the rest of the panelists speak in English, in Spanish, sorry, and we have a translation for all of our attendees. Okay.
Okay. I don't see at the moment. On my screen, it's written Alvaro Traductor. This is where I should go.
Let me. ¿Quién está de operador logístico en la sala B?
Tatiana, parece.
Tatiana, ¿cómo está? Pascal, could you share your talk?
Can you see my talk?
No, not yet.
No.
So where should I go?
Tatiana, ¿le podemos dar privilegios al doctor Wallo para que pueda...
No la puede compartir hasta que no inicie la transmisión.
Ok. Pascal, you can share the talks until we start the transmission, okay?
So, where is my this one?
Hi, Pietro.
Can you see my talk now?
Yeah.
Yes, we can see.
Should I make?
Your city with COVID good? It's better, no? Better than Spain. I heard that.
Do you want to try the videos?
In this one, I have a small video here. It works. Okay.
It's perfect.
Works perfect. So Pascal, we start at 2 p.m.
Yeah.
Times of our meeting is very, very nice until now. So we need to have time for discussion. I think is the most important part of the meeting. And of course, thank you so much. Very, very, very thank you so much for sharing your knowledge with us. For us, it's very, very important to have you here. Okay.
It's my pleasure.
Good. We have more than 300 attendees. We have two rooms A and rooms B. And in 2A, in rooms A is a knee, and room B, of course, the most important part of the body, shoulder.
Of course.
What time is now in France? 9 p.m.?
Yes.
In France, yeah, it's 9 p.m. almost.
Okay.
8:50.
Could you see the button of interpretation?
Yeah, interpretation.
Yes.
And I
You
should
can-
go in English.
Right.
Yes. Yes. When you put on English, our traductor speak in English for you and translated the discussion that will be in Spanish. Okay. So
Should I do it now or later?
no. Just in the discussion, okay? Because
Okay.
now everybody is speaking in English. Giuseppe and you, just in the moment of the discussion, okay?
Okay.
Doctor
How's
Bolo,
France?
Doctor Bolo, good evening.
Good evening.
La ciudad en Colombia es Medellín o Cali, alguna de esas dos. ¿No? Ok, y lo hacemos con slam, Joao.
Edgar, la voz del monstruo se oye durísimo. Sí.
Y ayúdame en eso porque para nosotros es importante.
Yo sí me puse la corbata, fui obediente.
Néstor,
Aquí estoy.
yo voy a estar aquí pendiente de algunas cosas, pero tú eres el dueño de esta parte, ¿ok?
Para mí es un privilegio que usted esté y que opine y que tome el liderazgo, no es problema.
No, para nada, para nada. Usted lo va a manejar de la manera en que quiera, ¿ok?
Sí,
¿Listo?
no había pensado en casos clínicos, simplemente preguntas.
No va a haber. Van a
lo que
haber
salga de
preguntas
las
solamente
conferencias y-
de la discusión y demás. No hay presentación de parte suya,
Sí, no, nada.
solamente, ok. La otra persona es Giuseppe, ¿cierto?
Sí, señor.
¿Giuseppe no se ha conectado?
No lo veo por acá. No está.
¿Usted se pudo conectar con él?
Yo,
Confirmé todo, sí.
hubo un correo de respuesta de él diciendo que había mandado las conferencias y en ningún momento dijo que no fuera a estar.
Ok.
Eso deberíamos hacerlo siempre nosotros y darle la palabra al moderador.
Buenos días, buenas tardes a todos. Dr. Boileau, thank you very much for being with us. For us, it's an honor that you be here. Ya son las 2:01 minutos. Vamos a dar inicio con la charla. Entonces, Tatiana, empezamos con el doctor Boileau y continuamos con las charlas enviadas por el doctor Milano. Néstor, que el auditorio es suyo. Muchísimas gracias por acompañarnos a todos. Néstor, el micrófono está apagado.
Buenas tardes, muchas gracias, doctor Boileau, por estar con nosotros. Es un momento difícil, viernes en la noche, poderse conectar para compartir con nosotros es un privilegio. Muchas gracias. Este bloque vamos a hablar de inestabilidad del hombro. El doctor Boileau nos va a hablar de inestabilidad en rupturas masivas y nos va a hablar de su experiencia con la cirugía de Lateral y los bloques óseos. El doctor Milano, que se acaba de conectar. Buenas tardes, doctor Milano.
Buenas tardes.
Nos va a hablar de revisión, de cirugía de revisión y de aumentación biológica en cirugía de inestabilidad. Para los participantes, por el chat pueden enviar las preguntas, las tendremos, al final tendremos una sesión de discusión. La traducción está disponible. Empezamos. Doctor Boileau, el auditorio es suyo.
Okay, thank you very much for the invitation. I'm going to share my screen here. And here. Can you see everything?
Yes, it's perfect, Dr. Boileau.
Yep.
So again, it's a great honor for me too to participate to this virtual meeting, and thank you very much to all my friends in Colombia and in South America. So my talk is about recurrent anterior instability in patients with massive cuff tears, massive rotator cuff tears, and I would like to present to you the rationale and the results of the 3R procedure in this instance. We know that when we have rotator cuff tear with anterior instability, we can repair the cuff and we can also treat the instability with a Bankart repair or Lateral procedure, for instance. But that's not the problem. The problem is when you have recurrent instability with a massive irreparable cuff tear and a non-functional shoulder, then you can do a reverse prosthesis. It's pretty easy to treat this kind of patient. The big problem is when you have a recurrent instability in a patient with a massive irreparable cuff tear and a functional shoulder, which means a normal active range of motion. What would you do in this case? And that's the question I would like to try to answer to you today. So as a case illustration, this is a 76-year-old woman with 5 previous anterior dislocation. You see that this lady is very active. She's doing yoga. She's swimming every day. She comes to see you for recurrent instability. She has no pain, no shoulder pain. She has a normal active range of motion in elevation and rotation. When you look at the X-ray, you can see that she has upward migration of the humeral head. She has no arthritis. And when you look at the CT scan or the MRI, she has a massive cuff tear involving the supraspinatus, the infraspinatus, and the long head of the biceps. There is already fatty infiltration of the muscle of the cuff, and there is no Bankart lesion. Only the subscap is intact. So what would you do for these patients? You want to do a Bankart, you want to do a Bankart and a partial repair, which means a remplissage. You want to do a Bankart and a full cuff repair, or a Lateral procedure, or a reverse shoulder prosthesis, or something else. I think there is no good solution. As you can see, the Bankart repair or the capsular shift is not a good idea because there is no Bankart lesion and there is a risk of making a stiff shoulder with also increasing the osteoarthritis. If you do a partial repair, it's almost not possible because there is no infraspinatus. And if you do a cuff repair, a full cuff repair, it's even less possible. And even if you succeed, for instance, if you do a subsuperior capsular reconstruction, there is having a stiff shoulder, and to transform a functional shoulder into a non-functional shoulder. This is also the risk with the Latarjet procedure, because when you pass through the subscap with the bone block, you risk pseudoporesis of the shoulder. So this is very bad. And of course, there is no place for the reverse prosthesis because this patient has no pain, no shoulder pain, and a normal active range of motion. So this is why for this patient, we choose to do an arthroscopic TRIA procedure. So TRIA just modified the procedure proposed by Noske in 1924, which is to do a partial wedge osteotomy of the coracoid process to lower and to metallize the coracoid and the conjoint tendon. And TRIA proposed to fix the coracoid process, which was osteotomized with a nail. And how does it work? It works because, as you know, when you put the arm in abduction external rotation, there is a risk of instability because the subscapularis is going up and only the capsule and the labrum are stabilizing the shoulder. And the TRIA procedure works because it lowers the subscapularis. So there is the sling effect with the reinforced anterior weak capsule, and there is also a kind of bone block effect because you partially close the subcoracoid recess. As you can see on this drawing, this is the effect of the TRIA procedure. This is a sling or seat belt effect. So Albert Tria has later replaced the nail by a screw to fix the coracoid process. He has reported excellent and good results. Gilles Valch, when he was a fellow in Lyon, has reported the results of 250 patients operated by Albert Tria himself with a follow-up of 11 years. And as you can see, very good results with 12% of recurrence of instability. And Christian Gerber in Switzerland also reported the results of this operation done open with 4% of recurrence. However, he found that there was pain in patients with insufficient medialization of the bone block and some kind of loss of external rotation in half of the patient with some osteoarthritis. So for our patient, what we did is an arthroscopic TRIA, you see, with a cannulated screw. You can see the X-ray, you can see the CT scan. There is no increase of osteoarthritis. This is the range of motion of the patient who is able to go back to swim and to do his yoga with a preserved active forward elevation and only slight loss of external rotation. As you can see here, on the pre-op and the post-op X-ray, there is a kind of increasing of the acromial distance, and you can see the effect of the medialization and the lowering of the coracoid process and the conjoint tendon with the screw. As you can see on this drawing, the fact that you lower the subscapularis may even help to lower the humeral head in case of rotator cuff tears. So this is our experience with this procedure. We use screw fixation initially, and later we use button fixation. We have 18 patients with unstable shoulder and massive irreparable cuff tears, mean age of 61 years, follow-up for almost 6 years. We had no complication. We observed no complications in this small series. We have one patient with a failed recurrence of instability, one patient with a persistent apprehension. But for those patients who are doing sport, 85% were able to go back to sports. And all but one patient were satisfied or very satisfied. So you see the evolution for us of the bone block fixation from the screw initially to the button with the anchors and now to the double button. And this is a small animation to show you how we do this operation today. We drill through the coracoid. We pass a peg button in the front. We drill the glenoid with a guide. We put the button in the back. We do a partial osteotomy of the coracoid. And we just lower the coracoid and we metallize the coracoid bone block and the conjoint tendon. As another example, this is a 47-year-old man, right-handed. He has a 10 dislocation in 4 years. He's a Paralympic snowboarder. He has a functional but unstable shoulder, as you can see, with normal motion. And on the X-ray, you can see that he has a massive cuff tear because of a sequela of a missed greater tuberosity fracture. So now he's like this. He has a massive supra-infraspinatus cuff tear because of the greater tuberosity fracture that was not diagnosed. He has fatty infiltration of the muscle of the supraspinatus, infraspinatus. He has normal active range of motion, no shoulder pain, and he wants to go back to competition. What would you do? Again, there is no good option, and the TRIA procedure is for us a very good option, because you can see that this patient has no pain, a preserved motion, but no more instability in the shoulder, and he was able to go back to snowboarding. And he sent me this video here, and as you can see, he's right-handed, and being a competitive snowboarder is very risky. But with the TRIA procedure, he was able to go back, and the evaluation of the shoulder for sport was 85% in this patient. And you can see the X-ray here with the button fixation. You can see the healing of the coracoid process. You can see that there is no misplacement of the coracoid process, which is just flush to the glenoid surface. And we observe healing in all our patients in this series. So as a discussion, we have this association of recurrent anterior instability with massive cuff tear. It's a rare combination, but there are two theories. The theory of the anterior mechanism, which means you have anterior capsulolabral detachment, the Bankart lesion, which is the main cause of shoulder dislocation. But you have also what has been called the posterior mechanism, and this has been described many years ago in the USA by McLaughlin. He has shown us that when you have a massive cuff tear, this recurrent dislocation can be the results of the posterior massive cuff tear. And this is very well illustrated on this drawing here in the publication of Ed Craig from New York, and was shown us that in massive cuff tears, there is no Bankart lesion most of the time, because the anterior labrum and the capsule act as a hinge while the humeral head is rolling over the anterior glenoid rim. So if there is no Bankart lesion, there is no Bankart repair possible, as you can imagine. And the TRIA procedure with under arthroscopy with button fixation is for us now the way to go. And of course, it should be indicated only in an elderly patient with massive posterior superior cuff tear, but with a functional shoulder, which means with preserved active forward elevation and external rotation. It is contraindicated in case of complete subscap tear, in case of pseudoparalysis, in case of isolated loss of external rotation, and of course, if you have too much bone loss on the glenoid or on the humeral side. So as a take-home message, in case of unstable and cuff deficient shoulder, you can repair the cuff sometimes, and you can also do the Bankart repair in the same session. Sometimes when you have a massive cuff tear, which is not reparable, and you have a non-functional shoulder, of course, you can treat the instability and the cuff tear with the reverse prosthesis. But in the patient with massive cuff tear, which is not reparable, with a functional shoulder and recurrent instability, the TRIA procedure is for us the best option. This is really the only solution for this kind of patient. And we have shown that the guided procedure allows accurate bone block positioning. With the cortical button is a reliable fixation with predictable bone block healing. In addition, it simplifies the graft transport, and it's an extra articular procedure which is less technically demanding than the arthroscopic Latarget and less risky for the subscapularis. So when you want to start to do a kind of bone block under arthroscopy, starting with the TRIA procedure is a good idea. It's a kind of transition for doing the Latarget later on. Thank you for your attention.
Muchas gracias, doctor Baló. Continuamos con las conferencias del doctor Milano que están pregrabadas. Gracias.
This is Giuseppe Milano from Brescia, Italy. My talk is on arthroscopic revisions for failed open or arthro shoulder instability surgery. This is my disclosure of conflict of interest. Glenohumeral instability surgery can fail for different reasons. Unrecognized conditions like risk factors or anatomical deficiencies that are not addressed during the first surgery can contribute to failure of instability surgery. Technical errors, most of the times, are the main reason for failure of surgical arthroscopic or open procedures, but also new injuries can contribute to failure. Regarding arthroscopic Bankart repair, this is a recent systematic literature review that showed total recurrences are around 31%, which is really too high to justify the use of this technique as a routine procedure or first option to address shoulder instability. Risk factors of failures of arthroscopic instability procedures are related to different conditions: young age, generalized joint laxity, participation in contact or collision sports, and bone defects on both sides, humerus and glenoid, have been recognized by different authors as the most important risk factors for failure. But also capsular defects can contribute to failure, like unrecognized capsular tears, anterior or posterior, capsular insufficiency, redundancy, loss of glenoid concavity, labral attenuation or insufficiency. All of these conditions can contribute to failure of arthroscopic Bankart repair. And when we look at the treatment algorithm for treatment of bone defects associated to anterior shoulder instability, as reported by Giacomo some years ago, we should look at bipolar lesion bone defects when the glenoid defects is under the subcritical size, the 13%, and we have a small on-track Hill-Sachs lesion. Arthroscopic Bankart repair is for sure the first option. And when we have a large glenoid defect and a large off-track Hill-Sachs lesion, this is a condition in which bone reconstruction on both sides should be considered with the Lateral and eventually also a humeral head bone graft. Then we have some conditions in the middle, the so-called gray zone, where we should consider different options, but in which a Lateral procedure should be the first option. When we have a small defect on the glenoid side, but an off-track lesion, arthroscopic Bankart repair and remplissage or Lateral should be considered. When we have a large glenoid defect and regardless of the size of the humeral head defect, Lateral or bone augmentation procedure should be the first option. Also, Lateral can fail. This could be due to technical errors, non-union resorption or the coracoid, capsular hyperlaxity, large defect on the glenoid or on the humeral head. And this has been reported in several studies. And also in these recent studies, the authors show that when we have an off-track lesion after a Lateral procedure, the risk of failure of a Lateral is increased fourfold. So bone defects should be considered as a bipolar condition, bipolar lesion, and both of them should be taken into account. So what to do when our procedure failed? First option is for sure open surgery. When we look at this systematic literature review about different options considered for revision surgery after failed anterior shoulder stabilization, we can see that most of the procedures are open, Latarjet, open Bankart, or other open procedures. But if we consider the risk of retear, the risk of failure, arthroscopic Bankart repair or Latarjet procedure have a similar recurrence rate. For sure, the so-called other open procedures, so combined different procedures, have been reported with the highest recurrence rate. Latarjet procedure for failed arthroscopic Bankart repair is actually the first option. Many authors reported that this procedure is very successful, no recurrence, no revision surgery, as reported by Gerber. But in this recent study, the authors compared the results of the Latarjet as a primary or revision surgery, and they pointed out that results, subjective and functional results, are significantly worse in the Latarjet as a revision procedure compared to the primary one. Edenibnet is an option when the Latarjet fails, and many authors showed a good bone healing of the graft, with some problems related to the donor site, morbidity, and with some recurrence rate and a high risk of osteoarthritis. So the indication for Edenibnet is still questionable, albeit is a salvage procedure in case of failed Latarjet. Another option reported by Matt Provencher and his group is the use of fresh allograft of distal tibia, because it has the same contour, the same geometry of the glenoid, and it can restore a good glenoid concavity. And the clinical results in case of revision of failed Latarjet are very successful. But another condition that should be considered as a cause of failure, as I said before, is insufficiency of soft tissues. In these cases, capsular deficiency should be addressed with tendon augmentation procedures like the use of autograft or allograft. When used, for example, the hamstring tendons with a bone attachment, you can address at the same time soft tissues and the bone defects. Or Achilles tendon allograft, which the same is a good option to address bone defects and soft tissues at the same time. And this, in my experience, is a good option to restore glenoid defects, or also a combined glenoid and humeral head defects, because a part of the calcaneus bone is used to reconstruct the Hill-Sachs lesion. So, is there a role for arthroscopy in failed previous instability surgery? If you look at this recent study where the authors compared arthroscopic Bankart and open Latarjet, for sure, arthroscopic Bankart revision surgery has a very, very high recurrence rate compared to open Latarjet, where no recurrence was reported. And also some other authors reported a high recurrence rate in revision arthroscopic repair. But these studies recognize some risk factors for failures, like hyperlaxity, an off-track lesion, so untreated bone defects, a young age, and number of prior surgeries. So the patient and the lesion profile should be clearly assessed before doing an arthroscopic revision repair. For this reason, probably actually the gold standard for arthroscopic revision surgery is a bone graft. So an arthroscopic Edenibnet, as described by Lafosse, with screw fixation or with the use of buttons, as described by Pascal Boileau. Combined procedures are also described that combine the use of a bone graft and soft tissues like subscapularis stenodesis, as described by Maiotti, or the use of biceps tendon that augment the capsule and recreate the labrum. Also, arthroscopic capsule reinforcements have been described, like the BLS technique described by Roman Broszka, which make a tenodesis effect and increase the thickness of the anterior wall of the shoulder. The same is obtained with this arthroscopic subscapulary augmentation described by Marco Maiotti, which is an indication in case of small defects on the glenoid and humeral head combined with the capsular tissue insufficiency. Revision labral augmentation, as I described in a technique for primary buccal repair, can be considered an option in case of joint laxity with no critical bone defects and labral insufficiency. But finally, an extreme indication to arthroscopy has been reported by some authors. Cuellar reported an arthroscopic repair in a failed lateral G, and with the indications limited to small glenoid bone loss and capsule redundancy. And also Boileau reported a large series of 41 patients with a good recurrence rate, 12%, and a very successful return to sport. Risk factors were identified in severe bone defects on the glenoid side and unaddressed heel sacks when no remplissage was accounted. Thank you so much. This is Giuseppe Milano from Brescia, Italy. My talk is on biologic augmentation and arthroscopic bone repair. This is my disclosure conflict of interest. Causes of failure in surgical treatment of shoulder instability are related to several factors. New trauma for sure is an option. Technical errors is probably the most common cause, and strictly related to misdiagnosed lesions that should be addressed at the first surgery, like glenoid or humeral head bone defects or soft tissue defects, especially the mid-substance of the capsule of the attachment side on the humeral side. Other conditions that sometimes are underestimated and represent important causes of failure are related to insufficiency of soft tissues, like a generalized joint laxity, or capsular insufficiency, redundancy, or loss of glenoid concavity, which is related to soft tissues or bone morphology. More others showed in studies some years ago that the loss of glenoid concavity related to inherent flattening of the bony glenoid concavity or loss of cartilage in the glenoid rim are sometimes related to instability with some anterior and frequently multidirectional pattern. But also labral attenuation or insufficiency can be cause of instability and failure of instability surgery, as demonstrated in some studies. So labral augmentation has a rationale in these cases because it can deepen glenoid concavity and increases the joint surface area, so increasing the static stability of the glenohumeral joint. We described this some years ago, and indications are the shoulder instability with the insufficiency of the glenoid labrum that cannot be considered for repair to achieve an adequate bumper effect and any effect as a static restraint against anterior translation of the humeral head. So the surgical technique consists on an augmentation of the anterior labrum with a collagen membrane in a rolled up configuration. It is sutured on the anterior glenoid rim with permanent braided sutures. The membrane is rolled up and sutured with some vicryl, and 2 traction sutures are applied at the 2 ends of the graft. The diameter of the rolled patch graft is 5 millimeters. Length depends on the distance that should be covered, so on the length of the anterior rim. Size of the graft is established at the beginning of the procedure. So the length of the anterior rim is measured with a calibrated probe. Then the anterior rim is prepared in a standard fashion as for a standard arthroscopic procedure. Then a scaffold is pulled with traction sutures into the joint and is fixed at the most inferior aspect of the capsule with absorbable sutures. Then anchors are used to fix together with the capsule over the glenoid rim like in a standard bunker repair. This is the surgical technique. This is a case where the anterior capsule is patulous and the labrum is almost absent, and no chance for recreating any bumper with the native tissue. So the capsule is retrieved, is detached, and the anterior rim is prepared with the shaver and with the bar to have a bleeding. Then the traction sutures are used as a shuttle to push and pull the graft into the joint, and it's fixed at the most inferior aspect of the anterior capsule. Then capsule and the labrum, the artificial labrum, are fixed together with knotless anchors and permanent braided sutures. And this is the final result. As you can see, there is an increase of glenoid concavity, and the labrum is restored to have an effect against the human head. This is the first technical note published by Enrico Gervasi some years ago. We were working at the same project. He suggested the use for a multidirectional instability where there is a combined absence of glenoid labrum and flattening of the glenoid surface. We here report the case series in which the technique has been used for the treatment of anterior instability with insufficient anterior labrum. We have a 3-year follow-up, just one case of recurrence after 3 years, no intraoperative or postoperative complications reported. Clinical results are very promising. We observed a significant increase in all the outcomes considered. Row score, DASH score, and the WOSI score show a significant improvement. And at the MRI, we found a good integration of the graft with the surrounding tissues and on the anterior glenoid rim, and we observed a normal profile of the anterior labrum in terms of height and width compared with the contralateral shoulder. So some limitations in our study for sure limit its external validity because the sample size is for sure still small. We have no comparative group, and no analysis of factors affecting outcome was performed to assess adequacy and the correct indication of the technique. By now, we can say that labral augmentation can restore joint stability and show the good integration with the surrounding tissue, no adverse reactions. So it can be considered a safe and effective procedure with the limited indications in case of labrum insufficiency. Thank you so much.
Muchas gracias, doctor Milano. Continuamos con la conferencia, la cuarta conferencia, la del doctor Boileau, sobre su experiencia con la cirugía lateral y bloques óseos.
Thank you very much. My disclosure is with the Smith & Nephew company with which I designed the instruments and the implants that I will present in this talk. So we know that the Latarjet procedure is a fantastic operation because it solves the problem of glenoid bone loss and also the problem of soft tissue insufficiency with what we call the triple locking of the shoulder. You see the bone block effect, the soft tissue effect, and the muscular tendinous effect of the lowering of the subscapularis and
Pascal, sorry, we can see your talk. I'm sorry.
Okay, I'm sorry. Wait. Can you see it?
Yes, perfect.
Yes, we can.
Okay. So I was saying that the Latarjet procedure is just a fantastic operation because it reinforced the anterior-inferior weak point of the shoulder with this triple locking effect. You see the bone block effect, the capsular effect if you do the Bankart, and the sling effect of the conjoint tendon, which is lowering the subscapularis here. So I cannot advance my slide. Okay, so today the gold standard for doing the Latarjet procedure is to do it open, with open surgery, to eyeball for the screw fixation, and to use the screw fixation, of course, and 2 screws is the recommendation. What I would like to show you today is that the Latarjet procedure in 2020 should be done under arthroscopy with a guided technique using cortical button, and that you should stop using screws. So why should you stop using screws for Latarjet procedure? Because it's a cause of problems and complications. Because it's very difficult to be parallel to the glenoid surface, and because of that, because of the obliquity of the screws, you have impingement with the humeral head, you have painful shoulder, you have osteoarthritis. Even in the best hands, like the ones of Gilles Valch, you have 20% of incorrect bone block positioning after open Latarjet procedure, sometimes medialized, but more often lateralized, overhanging. As I said, it's almost impossible to be parallel to the glenoid surface, especially if you try to do this operation under arthroscopy, because you're drilling from the front. It's also very dangerous because you have all the brachial plexus, and especially the axillary nerve and the musculocutaneous nerve, which are closed there. And under arthroscopy, you're going to drill and you're going to come from the front with a screwdriver and the screw, and you're going to put at risk the brachial plexus. Also in the back of the shoulder, if you have excessive length of your screws, you will create pain because you will damage the suprascapular nerve. So now what we see in the publication is that surgeons like Thibault Lafosse and Laurent are doing revision surgery to remove the screws after arthroscopic Latarjet, and they explain to us how to do this operation. If you look at this article here from Leutzinger, who was a fellow with Laurent Lafosse, you see that he published a very important series of 132 patients with an arthroscopic Latarjet done with the technique of Lafosse. And yet to revise 40 patients, 40 shoulders, 37 patients, so 30% of revision. He has to revise 25 patients for stiffness, for pain, and to remove the screws. You have some broken wires, you have patients with hematoma, he has patients with recurrent instability, and he has 2 patients with neurovascular complication. So why you should start using cortical button for Latarjet procedure? Because it's very simple to use, number 1, but number 2, it's very strong fixation. And even an engineer in the first year of study knows that if you use a bolt or a rivet, mechanically it's stronger than a screw or even 2 screws. If you look at the cone of pressure of the screw on the left-hand side, which is very small here, if the green here is the bone block and here it's the glenoid, you see that the cone of compression is very small in the scapula. When you use a bolt or a rivet, this is the cone of compression, the cone of pressure that you get. So that's why we use a tensioner to put compression and to transform the sutures into a rigid bar. Exactly like this, it becomes like a rivet or a bolt. And obviously, 1 cortical buttons or 2 cortical buttons, 1 in the front, 1 in the back, is superior to 2 screws. You're going to say, oh, that's not true because you're using you're using soft suture. And I can tell you that if you tell me that, it's because you don't know about sailing boat. Because if you would know about modern sailing boats, you would know that all the metal has been replaced by textile. And this is the old-fashioned style of doing sailing boat, and this is the modern style. And you can see that these boats are very fast. And one of the reasons they are very light because they have replaced all they can on the boat, everything in metal by textile. Textile today is very resistant, as much as resistant as metal. And again, a rivet is stronger than screws. And as you can see, unfortunately, we cannot travel today, but when we were traveling on the plane, the wings of the planes, there is no screws, only rivet or bolts. So why you should use a guided technique? Because if you use a guided technique like we do here, you start with the coracoid preparation, you do the osteotomy of the coracoid process, you do the preparation of the glenoid, you drill the glenoid with a guide, and then you make the split with specific instruments, spreaders. Then you can transfer the bone block with the suture and the button, and you can add a button in the back. You can do a sliding locking nut. You can use a tensioner, and then you obtain compression of your bone block exactly like a rivet or a bolt. Then you make the definitive fixation with 3 additional nuts. I want to show you this operation done under arthroscopy with the north, south, west, and east portal and the northwest in front of the acromion. We use a 70-degree scope coming from posterior. And as you can see, there is a small in-sacs lesion that we don't need to fix. We introduce the vapor from the front in the anterior superior portal. We are looking for the subscapulary tendon. And if we follow the subscapulary tendon from lateral to medial, we're going to reach the coracoid process. We can work also on the subdeltoid space. Now we can choose the north portal with the needle to pass through the pec minor. We can detach the pec minor. We are still with a 70-degree scope looking through the rotator interval, and we can make hemostasis. Now we can prepare the undersurface of the coracoid using a motorized rasp, as you can see, because we want to obtain a flat surface with cancellous bone. Then we can do the lateral portal, the distal portal, and the medial transvector portal. We can pass a suture around the conjoint tendon if needed. We can drill the coracoid process using a specific guide with 3 arms, as you can see. We're going to go distal, medial, and lateral. And we want to see the medial arm of the guide, which means we should incline the guide 45 degrees to be orthogonal to the coracoid process. Using a specific K-wire, which has a male and a female part, we can introduce a PDS suture that we will retrieve on the lateral portal of the shoulder here. This PDS will allow us to shuttle the 4 strands of sutures with the anterior peg button inside the shoulder, as you can see here. This is the peg button that we introduce in the coracoid process here. Now we need some suture management. We retrieve the blue suture through the south portal. We retrieve the white suture through the north portal, and we put this in the waiting place. Now we can use a motorized saw to make the osteotomy very quickly. And now we can start to work on the glenoid side. We're going to prepare the glenoid and drill the glenoid. So we put a stick to push away the labrum and the capsule. We detach the labrum and the capsule from the glenoid neck, as you can see. Again, you see the view given by the 70-degree scope. And we're going to pass a suture through the labrum at 5 o'clock. And this suture will be a hole like this to put away the labrum and the capsule. Now we can prepare with the same motorized rasp the neck of the scapula to make a flat surface with cancellous bone. We can introduce one anchor at 3 o'clock here on the glenoid rim. This will be used to make the Bankart repair with the PDS suture later on. And we can put even another suture anchor at 6 or 5:30, 6 o'clock position. Now, for the first time, we changed the scope in the lateral, anterolateral portal, and we introduce a glenoid guide from posterior to anterior through a half pipe. We're going to hook the glenoid neck in the front, and we're going to drill from posterior to anterior. So it's very safe. We are far away from the brachial plexus. We are inside the joint, and there is no risk, number one. And number two, we are sure to be parallel to the glenoid surface. As you can see, we use the same kind of K-wire with a male and a female pair. Then we can retrieve the glenoid guide, and we can introduce the posterior spreader, as you can see here. We're going to go at the same level as the K-wire, and we're going to push on 1 centimeter the spreader through the subscapularis muscle. Now we move the scope to the lateral portal, and we make the bursectomy of the subscapularis, and we look for our spreader coming from posterior. Using a specific nerve protector, we can just protect the axillary and the musculocutaneous nerve, and opening the posterior spreader here, which is passing through the subscapularis, we can open the muscle, as you can see. Now, it's easy with the vapor to continue the opening of the muscle and tendon. Here we go on the tendon side. We keep the capsule because we're going to use it for the Bankart repair. And now we come to the medial portal, the Transvector Portal with a long half pipe, which allow us to introduce the second spreader, and it's done under vision, so there is no risk for the brachial plexus. We can open the second spreader from the front here to create a real window through the subscapularis muscle. Now we reintroduce the suture inside the joint, in the shoulder. We capture the suture with a suture retriever in the back of the shoulder. We retrieve the female part of the K-wire. We can remove the PDS, and now we can slide the suture and pull the bone block inside the joint through the muscle of the subscapularis. We play with the posterior spreader, which is put more horizontally to let the passage of the bone block here inside the joint. We clamp the posterior suture here. We had the second buttons, which is a single hole button in the back of the shoulder. We can now cut the blue suture here, and we can tight our knot, which is a Nis knot, a square knot, and a loop, and you pass the 2 strands of suture in the loop, which gives you a sliding locking knot. By pulling on the suture, after removing the clamp, you're going to introduce the button inside the joint posteriorly, and you're going to introduce the knot as well. So now you use a tensioner, and you're going to put first 50 newtons of tension. You're going to control the rotation of the bone block, and then you can put 100 Newton of tension on the bone block. Looking again inside the joint from posterior, you can see your bone block, which is flush. It's always flush because it's automatic positioning. And you can do the Bankart repair at the end of the procedure, as you can see here, with 1 or 2 sutures to cover the bone block. Now we're looking from the front, we're putting a 100 Newtons 2 or 3 times to make sure that we have a perfect compression of the bone block against the neck of the scapula. And we can remove the second spreader from the front, and we can see the brachial plexus and the conjoint tendon going through the muscle. You can see here we have tied the knot definitively. So this is a accurate positioning because there is a matching between the coracoid and the glenoid drilling, as you can see on this CT scan that we have done for all our patients at 2 weeks and at 6 months to control the bone healing with 97% of bone block healing. So this is my take-home message. Forget about the screw fixation. It's a source of complications and revision surgery. It makes the arthroscopic lethargy difficult unsafe and unreproducible. If you travel sometimes after the COVID epidemic, you will remember this talk because you will look at the wings of your plane and you will see that there is no screw on the plane. There is only bolts and rivets to fix the pieces of metal. Otherwise, the plane would crush down because the pieces of metal will not stay in place. And the cortical button fixation under arthroscopy makes the arthroscopic latarjet simple, safe, solid, and reproducible. And I do believe that even if you do the open latarjet today, you should stop using the screws and you should use the buttons because it's safer, really safer, and it's stronger as well. So if you ask to this lady who has been operated in another center on the right-hand side and in Nice on the left-hand side, if you ask her, which shoulder do you prefer? She will tell you, I prefer the left for two reasons. There is no scar and there is no screws in my shoulders. So of course the open latarjet works, of course the screw works, but today in 2020, I think we should go a step forward and we should use arthroscopy and we should use button fixation. Thank you for your attention.
Muchísimas gracias, doctor Baló, por su conferencia. Tenemos 10 minutos para preguntas. Del auditorio hay una pregunta para el doctor Baló sobre la cirugía de trillat. ¿Cómo maneja el pectoral menor? Do you release the pec minor at the trillat surgery?
So for the trillat procedure, you should not touch the pec minor. You have only to cut the coracoacromial ligament. And this is not needed. It's not like the latarjet, where you have to cut the pec minor. In the trillat, you don't have to cut the pec minor. So you just conserve it.
En algún momento en su conferencia, usted nos habló de hacer la transición del latarjet abierto artroscópico haciendo cirugías de bloque óseo. ¿Cuál sería la secuencia que usted recomendaría para las personas que no tenemos el volumen quirúrgico tan alto para hacer esa transición? Iniciar con trillat sumado a un replissage, a una reparación de ACCART. ¿Cómo sería esa transición?
No, I think you should first manage nicely the open latarjet, and I think you use cortical buttons with open latarjet. Because you will realize that it is very strong and that it provides bone healing. The first step for me is to manage the patient with open latarjet and cortical button fixation for the bone.
Okay, muchas gracias. Pregunta
Then
para
the second step is to do preparation of the glenoid under arthroscopy and then to do it open. Next time you do the coracoid preparation under arthroscopy and then you do it open. And progressively, you get confident. You also, if you can get a 70-degree scope, it's better. It provides a better vision. So you get used to the 70-degree scope. And then one day you will do everything under arthroscopy, all the steps with cortical button fixation.
Mosco.
Gracias. Es una pregunta para el doctor Boileau, pero también para el doctor Giuseppe Milano. Está de moda la reconstrucción capsular superior para las rupturas masivas. ¿Qué opina de usar la reconstrucción capsular superior y anterior para no hacer un trillat?
en el ejemplo del paciente que mostró en la conferencia?
So for me, I'm sorry to say that there is no place at all for superior capsular reconstruction. I don't believe in this operation. I don't do an operation that I don't understand.
Okay. But do you think that is a room?
I think that doing this operation in a patient with an unstable shoulder, the massive cuff tear, but a functional shoulder, which is normal elevation, is very risky because you can transform a functional shoulder into a non-functional pseudoparalyzed shoulder. So I would not recommend at all to do that.
Okay, thank you.
Yo tengo una pregunta para el doctor Giuseppe Milano. La artrosis es considerada una causa de falla, de inestabilidad. ¿Cuál es su abordaje? ¿Qué porcentaje de pacientes con bancar artroscópico y con Lateral desarrollan artrosis y cuál es su manejo?
So the question is the risk of osteoarthritis, right? I understood. In bancar repair and in Lateral.
Yes.
Okay. I would say that literature reported a risk of osteoarthritis, late osteoarthritis in both procedures. So we should consider that when we make our surgery, when the cartilage degeneration already started because of long-lasting history of instability, probably our surgery is not so effective in decrease the risk of late osteoarthritis because some instability arthropathy already started and cannot be completely restored. That said, my personal feeling is that Lateral procedure, if performed with a combined capsular reconstruction, is more effective in restoring a normal shoulder kinematics and in limiting the risk of late osteoarthritis. Because when you have a shoulder instability, the main goal for sure is to restore stability. But you should consider that Lateral is not able to restore kinematics of the shoulder, normal glenohumeral kinematics. It's just a restraint, a very strong and effective restraint against dislocation. But if you add a soft tissue procedure like a ACCART or a capsule, a reattachment, capsule repair, probably you have a better function, better kinematics of the shoulder and less risk of osteoarthritis, which is not only related just to the risk of impingement of humeral head against the bone block. It's a matter of kinematics in my feeling. And the same is for bancar. So when you have a very weak, a very inconsistent capsular tissue, just a bancar repair probably can reduce the risk of dislocation, but patient continue to have a feeling of instability, some apprension, and this kind of shoulder has a higher risk of late osteoarthritis, not only recurrence, but this because you have some change of the glenohumeral kinematics. This is similar to the knee when you just reconstruct the ACL, but you have some lengthening of the peripheral structures, and then the central pivot reconstruction is not able to limit the risk of late osteoarthritis because you have some change in the joint kinematics because of extra-articular injuries.
Otra pregunta para señor.
No, ¿qué opina el doctor Giuseppe Milano en relación a su aumentación con Matrix? Si es posible cambiar un tejido extraño por el uso del bíceps.
Yes, I would say that the biceps has a role in stability, and we should consider that we are treating young patients, so we don't have to alter too much anatomy of the shoulder. So probably not the biceps, but the SMIT or the gracilis tendon, double or triple gracilis tendon is a good option, is an autograft, is a viable tissue, and I start doing a gracilis instead of a patch graft with satisfactory results, satisfactory feedback. Yeah.
Sobre esas mismas cirugías, yo quería preguntarle, además de la aumentación del labrum, ¿hubo algún procedimiento adicional? ¿Hubo pacientes con remplissage?
They have different indications. You can do both, of course, because the indication, my personal indication for this procedure is just cases where labral repair cannot be addressed because the quality of the tissue is very poor. So just a capsule reattachment without any bumper effect in the front of the shoulder cannot be achieved with a standard Bankart. Regardless of that, if you have an off-track lesion with no or small defect on the glenoid side, remplissage is an additional procedure that can be performed at the same time.
Gracias. Doctor Boileau, creo que alcanzamos una última pregunta. Yo quería oír su opinión sobre el artículo que escribió el doctor Di Giacomo modificando su escala de ISIS para la inestabilidad. Él adiciona el concepto de off-track, in-track para tomar decisiones. ¿Usted qué piensa de esa publicación?
I must say that I read the article twice at least, but I have difficulties to understand the concept. For me, the concept of on-track, off-track is a very nice concept, but I must say that I'm not able to use it in my practice because it's very theoretical. And I think that whatever we do, we always try to measure the bone loss on the glenoid side and on the bone side, but we don't know how to measure the laxity, the elongation of the capsule and the ligament. So since we are not able to measure the elongation of the soft tissue, I think that all the concepts that take into account only the bone loss are wrong. Because you can have a patient, or I give you an example, you can have a patient with only 10% of glenoid bone loss, and he will have a failure after a Bankart repair just because he's hyperlax and he has a very thin capsule and very elongated ligaments, glenohumeral ligaments. So I think the surgeons always want to measure the bone loss on one side, but they don't know how to measure the soft tissue, the elongation on the other side. So they're missing half of the problem. They only answer to one question, while there is at least two or more questions. You understand?
Muchas gracias. Son las 3:05, creo que tenemos el tiempo agotado. Muchísimas gracias por compartir con nosotros. Fue fantástico todo lo que vimos y aprendimos. Esperamos que pase la pandemia y podamos volver a Niza y a Italia a disfrutar de sus congresos. Muchas gracias.
Thank you, Nestor. I just want to say thanks to ACCART, to Colombia. As you know, Paulo, Manuel, and you, we invited Colombia as a guest nation at our first annual meeting in ACCART annual meeting in Rome next year. Probably the meeting will be a virtual meeting again. So in any case, you will be with us on February for the national meeting of the Italian Society of Arthroscopy, Sports Medicine, and Surgery. So thank you so much for inviting us.
Thank you so much. Thank you so much, Giuseppe. We confirm that ACCART is our invited society in the next meeting in Barranquilla. So we are very happy to receive the Italian people and colleagues in our country. Again, Pascal, thank you so much for your time, for your knowledge, and for sharing everything. See you soon, I hope.
Gracias muchas.
Bye-bye.
Gracias, Mile.
Muchas gracias.
Gracias a todos.
Néstor, excelente.
Los invitamos a la muestra comercial. Muy bien.
Excelente.
Ya, grande, entonces fue. A Pascal. Y Rosetta.
Non, je vois.
É, porque eu fui na sala para pegar um cobertor.
Frances, qué gusto oírte. Pon tu micrófono abierto, por favor.
Bien, ¿me oyes?
Ahora sí, perfecto.
Fantástico.
¿Cómo estás?
Bien, bien. Oye, fantástica la charla de Pascal, ¿eh?
Qué increíble, ¿no?
Sí,
Impresionante.
sí. Siempre es un placer oír a los maestros.
Impresionante. Impresionante.
Buenas tardes, buenas noches.
Felicidades
Ahora sí, perfecto.
por el Congreso.
Bien,
y fantástica la charla de Pascal, ¿eh?
Qué increíble, ¿no? Impresionante.
Siempre es un placer.
John.
Hello,
Good
can you hear me?
afternoon. Yes, perfectly.
Excellent. Good afternoon to all of you. Thank you for having me.
Oh, no, thank you so much for having you. Very, very kind to
Hello,
share
can you hear
your
me?
knowledge and we are honored to have
Excellent.
you.
Good afternoon to all of you. Thank you for having me.
Good afternoon, John.
Thank you so much for having you. Very, very kind to share your knowledge and we are honored to have you.
Good afternoon to all of you. Thank you for having me.
Thank you so much for having you.
Maybe I'll try
este
taking my
momento-
microphone off.
Yes. Todos, por favor, con el micrófono apagado ahorita para evitar el...
Maybe I'll try. Is it better?
Better. Yes,
It's
better.
I think.
Much better. We have a little delay when the microphone is open.
Okay.
So
I will make
until
sure that
start,
I mute myself when I'm not speaking. Yeah.
Okay, perfect.
Fabio, it's good to see you, my friend. Thank you for inviting me.
En el otro lado estaba perfecto, una sábana blanca. O verde oscura si quiere, mejor. Pero no, sábana blanca.
Fabio, por favor, pongamos todos los micrófonos en mute, por favor. Fabio. Doctor Armando Portilla.
Hola Pablo, buenas tardes.
Armando, ¿cómo te va? ¿Qué has hecho?
Muy bien. No, aquí, pendiente del simposio, espectacular. Espectacular todo.
Perfecto. Usted es el dueño de esta área, así que cuando sean las 5 en punto, en 2 minutos, dele rienda suelta al asunto y el escenario es todo suyo. ¿Ok?
Gracias, Pablo.
John, we'll start at 5 p.m. on time, okay? Francis, ¿todo bien?
Todo bien.
John, we'll start at 5 p.m. on time, okay? Todo bien.
Todo bien. Perfecto. Todo bien.
John, we'll start at 5 p.m. on time, okay?
Hay un poco de delay en el sonido. Me llega
Sí.
al cabo de de 20 segundos o así.
Sí. Deben cerrar, por favor, la presentación de ACCART virtual y quedarse solamente en el Zoom. Sí. Todos.
Segundos o así.
Sí. Deben cerrar, por favor, la presentación. No sé si me oyen en tiempo real, pero debemos cerrar la parte de para tener una comunicación en tiempo real, ¿ok?
Hecho.
Ok, Armando, 5 de la tarde. Empezamos.
Muy buenas tardes. Continuando con el simposio de actualización en cirugía de hombro, contamos en este pequeño simposio con dos eminencias a nivel mundial, el doctor John Tokish y el doctor Francis Soler. Vamos a tener dos conferencias de temas un poco variados, de pseudoparálisis versus pseudoparesia, cómo diferenciarlas y un tema de abordaje en el manejo y algo de actualización en las lesiones SLAP. Entonces, doctores Francis, doctor Tokish, bienvenidos. El auditorio es de ustedes. Muchas gracias por su participación.
Thank you for having us.
Muchas gracias por vuestra invitación.
Good afternoon, everyone, and I want to say thank you so much for having me and giving me the opportunity to be with you. I've had the chance to visit Colombia last year in Cartagena and fell in love with your beautiful country, and can't wait to come down and visit you again, and I hope that we can someday get back to doing these meetings in person. Thank you very much, and congratulations to the conference organizers. ACCART is a fantastic meeting, and I'm grateful to be a part. Today, I have the unenviable task of talking about pseudoparalysis and pseudoporesis and trying to figure out how we can all start talking about this condition or these conditions in a way where we can compare apples to apples. This has been a very challenging area with multiple definitions and a lot of confusion around this particular aspect of the massive rotator cuff. And so I'm hopeful that today we can discuss some of the constant definitions that we should all be using and thinking about, and then maybe present an idea about a treatment algorithm that we might be able to employ in patients with these massive cuffs. So without further ado, we'll get started on the topic of shoulders, pseudoporesis and pseudoparalysis, how to get a consensus and toward a treatment algorithm. When we talk about pseudoparalysis, classically, it's when we can't lift our arm due to a massive rotator cuff tear. This is a simplified definition, but this implies that you do not have a nerve injury or some stiffness issue, so that there is no limitation to the range of motion, but that you cannot lift this, usually due to a massive cuff tear. In the picture that you see here is one of my patients. He's a farmer, and he is trying to lift both arms overhead, as you can see here. This should be easy then. He should have bilateral pseudoparalysis. But he's 78 years old and he also has shoulder pain. And he's trying to lift both of his arms with his shoulders. Now, because he has pain, I went ahead and injected him. Once I inject him with cortisone or lidocaine and I repeat the exam, and you can see that now these arms are very, very different. On the left side, he has a very functional rotator cuff. So this is a problem of pain. Eliminate his pain, and you take care of his motion. This is not pseudoparalysis. On the right side, however, in spite of the fact that we've taken away his pain, his pseudoparalysis remains. This is a problem. Now, the problem in the world literature is we don't differentiate between the left arm and the right arm. In other words, we just do something that fixes your pain. Maybe we debride you or do rehab, and if we reverse the motion, we assume we've cured your pseudoparalysis. But this is not the case. If we are going to compare treatments for pseudoporesis and pseudoparalysis, we have to make sure that we're talking about the arm on the right in this gentleman's case. So lesson number one is that pseudoparalysis can be mimicked in a patient with pain. So before we can call it pseudoparalysis, we must make sure that they are out of pain. Now, you may think this is obvious, and it should be, except that when we look at the literature, no study in the literature does this, as I'll get to in a moment. Problem number two is confusing definitions. If you want to search the world's literature for the definition of pseudoparalysis, it's often not defined. Some people talk about anterior superior escape. Some people talk about just a shoulder shrug, that's all you can do, or no active motion. But when it is defined in the literature, usually people define it as active elevation less than 90 degrees. Well, this raises a problem, because if you can then take a patient less than 90 and make them greater than 90, you have cured pseudoparalysis. At least that's the theory. So you can see the problem with this. Let me show you. This is a man here that I examined. He had 85 degrees of elevation. And then we take him to 95 degrees of elevation. And all of a sudden we say to this guy, oh, you're cured. Well, this is silly. Nothing could be further from the truth. We haven't fixed this guy. We've taken him exactly 10 degrees. This is no victory. And yet, this is what the world literature really does. Because if you have a hard and fast definition at 90 degrees, anything above 90 is success, anything below 90 is failure. You must be careful. So these two arms in this picture are not the same. In the patient on the left, he has a condition that Christian Gerber originally called pseudoporesis. So paresis being weakness, but not paralysis. So pseudoporesis is a patient who has functional use of his arm but can't get above 90. And this is a different animal than the patient who has pseudoparalysis, the patient on the right, who has no ability to lift their arm even in the absence of pain. Problem number 3 is that we've been talking about pseudoporesis and pseudoparalysis for a long time, always in the terms of the ability to forward elevate, so in this plane. The problem is that many patients have a problem with external rotation too, the so-called hornblower sign that is shown down here, and can be very disabling to patients. If we don't take into account a patient who has ER, or external rotation pseudoparalysis, we miss half the picture. So if you have a patient who has a severe hornblower sign and you fix them because you restore elevation, but they still are here, this is no victory. So it's very important that we classify our definitions so that we get together and discuss these terms so that we're all comparing apples to apples. So we must fully classify the motion loss in the massive rotator cuff tear. So it must be relatively pain-free. It must be due to a massive rotator cuff tear, and we must document both the loss of forward elevation and external rotation must be appreciated. And finally, something that we don't talk about very often is we have to recognize the degree of arthritis. If you have a patient who has terrible arthritis and you treat them as if they have pseudoparalysis, you're going to maybe help restore some of their function, but you're maybe not going to be able to help their pain. And this becomes an important question in terms of the algorithm. So if we're able to put all of this together, well, we looked at the world's literature and did a large systematic review in the Journal of Shoulder and Elbow Surgery a few years ago now. And what we found was if we went to the literature and found every study that has been done on pseudoparalysis, there are 16 in the literature. And what's interesting is that there are 6 different approaches described to treat this. Non-operative rehab, rotator cuff repair, muscle transfer, hemiarthroplasty, reverse shoulder arthroplasty, reverse shoulder plus muscle transfer. And guess what? When you go to these individual studies that all are treating pseudoparalysis, they all work. Well, this is a problem because clearly in a patient who has, like my first patient who could lift his arm after I relieve his pain, non-operative rehab, biceps tenotomy, these are good approaches to the patient who has pain, but they're not going to restore the patient who has anterior superior escape. It's not going to happen. Just like the patient with the hornblower sign, if you do a biceps tenotomy or non-operative rehab, this is not the pseudoparalysis that's going to be fixed. So our plea in this paper was that we have to make sure we have a better definition of pseudoparalysis and pseudoporesis so that when you and I are talking about what approaches we are applying to each of these patients, we know that we're talking about the same thing so that we can critically evaluate our own results into situations that work and situations that don't. And how we treat a patient depends on their response to this pain injection, their amount of pain or their amount of arthritis on the film, and what the quality of their muscle is left over. So let's spend a little bit of time doing this. So what if they all work, what should we do? So at least let's define our terms, right? So studies should truly compare pseudoparalysis. So we must ensure that we start with painless inability to elevate. And as I said earlier, you might think this is obvious, but of the 16 studies that we reviewed in our study, none of them did this. Not one of the 16 studies took away pain as part of their algorithm. So then the next thing is we have to talk about age. We have to talk about Hamada stage. This is an evaluation of cuff tear arthropathy. And we have to talk about patient preference and expectations. If you get these and understand it, then I think we can have a clear path on which treatment algorithm works best in each of the definitions of pseudoparalysis. So this is the slide. And the truth is the first question you're going to get is age. So at the very top, you see this is a middle-aged adult. The patients that I think have the most latitude on what we can do. 50 to 70 years old with pseudoparalysis. So we begin at the top here with a massive irreparable cuff and can't elevate. The first question you want to ask is, do they have cuff tear arthropathy? Is this severe? So Hamada, as you know, can be divided into 5 stages. Stage 4 and 5 are severe arthritis. If you're a 50 to 70-year-old and you have severe arthritis, do not mess around with any of these soft tissue transfer procedures. Just go right to the reverse shoulder. This is a good option for them. It's a long-lasting option. It's been shown in Europe and North America, as well as South America, to be a very lasting result. But if these patients are young and they are Hamada stage 1 through 3, well, then the next question you have to ask is their muscle alive? And I always tell my fellows, if the muscle lives, there's hope. There's hope while the muscle lives. So if there is good muscle and they don't have bad arthritis, then if the muscle is alive in good shape, we will do SCR. And I'll talk in a later talk about this one. If there is no good muscle, but they're young and with no arthritis, I think this is the perfect indication for tendon transfer. And my preferred tendon transfer is Bassam Ellison's treatment of lower trap transfer to the greater tuberosity in this case. Okay, but what about they're very young? In the patient who is very young, let's say they're 50, and unfortunately we see these patients, in the 50-year-old patient or the 40-year-old patient or the 30-year-old patient with pseudoparalysis, now we take a look here and we say, well, even if the patient has massive osteoarthritis or a cuff tear arthropathy, Hamada 4-5, I'm not willing to do a reverse shoulder in this patient. So this is the patient we would do a hemiarthroplasty and SCR, or an anterior capsular reconstruction around the front of his shoulder. Or I will put human dermal allograft or grafts on the inside of the joint to graft the glenoid there to buy them some time in this regard. And of course, if they have Hamada stages 1 through 3, we're right back to the question of if the muscle lives. If it does, we love the SCR. And if it does not live, then we have to do tendon transfer. Now this changes when we get to the older patient who has pseudoparalysis, so the patient who is over 70. If the patient is over 70, then I would tell you that I would take away most of the left side of the algorithm. This is an excellent choice for the patient with reverse shoulder. Now, yes, I've done patients with SCR and tendon transfer over the age of 70 in very unique situations. But the reverse, in my hands, I do not limit them after a reverse. I don't repair the subscap, and I let them fly on day 1. So they have no rehab. So they're very fast in terms of their overall return to their function. And so in an older 70 patient who is very low demand, the reverse shoulder arthroplasty, I go right to it without even worrying about the other forms of treatment here, yeah? So in conclusion, pseudoparalysis should be more strictly defined. We have to differentiate the shoulder that is painful versus the shoulder who has true functional complaints. We have to define the functional loss. A patient who has pseudoporesis is very fixable with many of the treatments that we have with tendon transfer or with SCR. A patient who has true pseudoparalysis, this is very, very difficult to solve. We have to take into account their age, their activity level, and of course the amount of arthritis. And if we do these things, then I think the treatment algorithms are best treated, and they continue to evolve. Younger patients with less arthritis and with functional complaints, we should reconstruct them. Older patients with more DJD and less functional demands, we should go right to reverse shoulder. And this has been an algorithm that has served me very well over the last 5 years. We continue to get better at the SCR and at the reverses and when to combine the two. But I think for the purposes of pseudoparalysis, let's get to the point where we're all talking about the same condition when we define it. And with that, I say thank you and good luck.
Francesc Soler, presidente de la Asociación Española de Artroscopia. Evidentemente quiero agradecer la amable invitación de la ACCART y del presidente de este congreso para poder participar en el mismo, a pesar de que las circunstancias nos obligan a hacerlo de esta manera virtual. Bien, la charla va a ser respecto a una actualización o que podemos aportar de nuevo respecto a las lesiones de SLAP. Tengamos en cuenta que vamos a hablar solo de las lesiones de SLAP aisladas, no asociadas a otras patologías. Hablaremos de la anatomía, de la función del tendón del bíceps, qué tipos de lesión de SLAP tenemos, el tratamiento de las mismas y qué resultados podemos obtener. Es muy importante la anatomía. ¿Por qué? Porque tenemos que evitar confundir las lesiones de SLAP con las variantes anatómicas perfectamente definidas que son el foramen sublaural, el complejo de Buford y el complejo labral del bíceps. Está claramente comprobado que si confundimos estas lesiones con lesiones, o que estas variantes, perdón, con lesiones de SLAP y las reparamos o las suturamos, pensando que son lesiones de SLAP, tendremos un problema importante de dolor y limitación de la movilidad del hombro tratado. ¿Cómo las visualizamos, estas variantes de la normalidad? Pues el foramen sublabral es una separación del labrum anterior superior respecto a la glena, pero que no hay una imagen traumática, y esto nos puede inducir a pensar de que puede ser una lesión suturable cuando no deberíamos tocarla. El complejo de Buford es como una extensión del labrum anterior superior hacia la parte medial, simulando un ligamento glenohumeral medio. Es una variante de la normalidad y tampoco hay que modificarla. Y por último, complejo labral del bíceps es cuando hay una supuesta desinserción del labrum superior respecto a la glena, pero podemos visualizar de que la glena está recubierta por cartílago, con lo que realmente no es una desinserción verdadera. Es importantísimo diferenciar estas variantes de la normalidad respecto a las lesiones de SLAP. Como ustedes pueden ver, en las artroresonancias puede inducir a confusión. A pesar de ello, en la imagen superior de su izquierda pueden ver lo que sería un complejo labral del bíceps, en la imagen inferior izquierda lo que es realmente una lesión de SLAP. Pueden apreciar la diferencia. A nuestra derecha vemos la imagen artroscópica de lo que sería un foramen sublabral y la imagen a nivel derecha inferior de lo que sería en la artrosresonancia dicha imagen. Podría inducir a pensar de que es una ruptura del labrum anterior superior, pero realmente es una imagen típica del foramen sublabral. La función del bíceps tampoco la tenemos clara. En estudios biomecánicos cadavéricos de electromiograma y estudios biomecánicos in vivo se han definido varias funciones, pero que hoy en día, en el año 2020, aún tenemos la imposibilidad de reproducir cuál es la función real del tendón del bíceps. Tipos de lesión. Ya Andrews en 1985 definió lo que era la lesión de SLAP. Posteriormente, de todos conocido, Snyder en el 1990 definió los 4 tipos. El tipo más frecuente y el más problemático es el tipo 2, A, B o C, según la lesión que se extienda hacia anterior, posterior o ambos lados. ¿Y cuál es el tratamiento? Bien, el tratamiento de la lesión de SLAP, cuando la teníamos bien identificada y la suturábamos, la experiencia es que el tratamiento no era muy bueno en cuanto a resultados. Teníamos persistencia de dolor y limitación de la movilidad en un alto porcentaje de pacientes. En 2009, el grupo de Pascal Valós nos sorprendió mediante esta publicación en la que en deportistas profesionales de alto nivel, en lesiones aisladas de SLAP tipo 2, en un grupo reparó la lesión, en otro grupo realizó una tenodesis del tendón de la porción larga del bíceps y, sorprendentemente, los resultados fueron que el grupo de la tenodesis, la reanudación de la actividad deportiva al mismo nivel previo de la operación era muchísimo mayor que en el grupo de la reparación, como ustedes pueden ver. ¿Y por qué fracasaban la reparación de la lesión de SLAP? Pues bueno, tampoco lo sabemos seguro, pero hay varias teorías. Puede ser un déficit de vascularización que se da en la porción anterosuperior de la glena, que está perfectamente definido a nivel anatómico. Puede ser por el mecanismo de producción. Una cosa es una lesión traumática aguda y otra cosa son lesiones o mecanismos de producción de pequeñas lesiones, pequeños movimientos de repetición, como puede ser una subluxación inferior de la cabeza humeral repetida, como bien ha sido demostrado. Se han definido diferentes factores pronóstico, y esto sí que hoy en día ya lo sabemos, en cuanto a la lesión de SLAP y el pronóstico en su reparación. Hay 2 fundamentales, uno es la edad y el otro es el mecanismo de producción. En cuanto a la edad, ya Snyder y Burns definieron en el año 2011 una comparativa de reparación comparado con tenodesis del bíceps e hicieron este resumen, este algoritmo en que al final la decisión de si se hacía una cosa o la otra dependía básicamente de la edad del paciente por encima o por debajo de los 40 años respectivamente. Este gráfico es curioso, es un gráfico del grupo de Boston, del grupo de hombro de Boston, en que desde el año 99 al 2010 podemos apreciar de que el número de reparaciones ha disminuido progresivamente y, por el contrario, el número de tenodesis del bíceps ha aumentado exponencialmente. En cuanto al tratamiento, si miramos estudios comparando la reparación con la tenodesis, este estudio es un estudio retrospectivo del grupo de J.P. Warner, 25 pacientes con lesiones aisladas de SLAP tipo 2. Comparando tenodesis y reparación, no encontraron diferencias en el score de ACES, satisfacción del paciente ni retorno al nivel deportivo, pero sí que atribuían mucha importancia en la selección de pacientes, edad y mecanismo de producción. Este estudio, publicado hace 2 años, una revisión sistemática y metaanálisis de comparación de ambos tratamientos, 5 artículos, 204 pacientes, no encontraron diferencias en el score de VAS, ACES, UCLA, en el número o la tasa de rigidez postoperatorio ni en la tasa de reoperación. Sí que es verdad que en el grupo de la tenodesis había una mayor tasa de satisfacción y de retorno al nivel premio de la competición, pero no era estadísticamente significativo. Si solo reparamos la lesión de SLAP tipo 2, esta revisión sistemática nos dice que hay buenos y excelentes resultados entre un 40 y un 90%, una horquilla muy importante. El retorno al nivel de la competición, aún la horquilla se hace mayor, entre 20 y 94%. Sí que es verdad que define que hay un peor pronóstico en aquellos deportes por encima del hombro y en aquellas pacientes de edad superior a 40 años en los que hemos reparado una lesión de SLAP tipo 2. Esto es un detalle técnico que me ha hecho variar mi práctica en cuanto a la reparación de las lesiones de SLAP. Está perfectamente demostrado, y este estudio fue el primero que nos abrió un poquito la luz al respecto, que poner un implante y hacer una sutura por delante de la inserción del tendón del bíceps origina o puede ser causa de pérdida de rotación externa del paciente. Entonces, esto hoy en día se le da muy importancia y sabemos que o colocamos los implantes por detrás de la inserción del bíceps o lo más alejado a la parte anterior. Y si realizamos una tenodesis, ¿cuál es mejor? ¿La suprapectoral o la subpectoral? Esto es una revisión sistemática y metaanálisis publicado este mismo año de 7 estudios, 409 pacientes, en que sí que concluyen que hay una diferencia significativa en el ACES score, aunque no clínica, en cuanto es favorable a la tenodesis subpectoral, pero no encuentran diferencias los autores en dolor en corredera bicipital, función ni aparición de deformidad de Popeye. Es decir, que clínicamente ambas técnicas serían comparables. Como conclusiones, pues tampoco hemos variado mucho ni tenemos muchos datos que aportar más respecto a lo que sabíamos hace unos años. Es decir, es muy importante identificar las variantes anatómicas, no hay que confundir estas variantes ni suturarlas pensando que son las lesiones de SLAP. Hay que identificar los factores pronóstico, edad y mecanismo de producción perfectamente identificados y que nos harán variar en cuanto al tratamiento. Repararemos aquellas lesiones en pacientes jóvenes y que tengan un origen claramente traumático y en pacientes ya a partir de mediana edad, más o menos 40 años, y lesiones causadas por sobreuso o movimientos de repetición, nos inclinaremos por la tenodesis del tendón de la porción larga del bíceps. Y si realizamos la tenodesis, es verdad que los resultados publicados hasta el momento dan los mismos resultados satisfactorios utilizando la técnica suprapectoral, subpectoral o incluso a la entrada de la corredera. Agradecerles nuevamente su atención en su invitación e informarles que dicha charla estará colgada en la plataforma videosdemedicina.com por si la quieren volver a visualizar. Igualmente les invito a visitar esta plataforma y si quieren colgar algún vídeo técnico de su práctica habitual, pues será bienvenido. Muchas gracias.
Muchas gracias, doctor Tokic, doctor Soler. Nos quedan unos pocos minutos para hacer algunas preguntas específicas del auditorio. Doctor Tokic, de acuerdo al esquema de tratamiento que usted está indicando, en términos generales, para los pacientes con una pseudoparálisis jóvenes, podríamos hablar de un momento o de hacer un tratamiento de reconstrucción. En pacientes de mayor edad, básicamente sería indicada una artroplastia. ¿Usted en qué momento podría indicar una combinación de los dos tratamientos, tanto de una artroplastia como un manejo de tejidos blandos, por ejemplo, con una transferencia tendinosa? Y esto va muy ligado a que hoy en día la tendencia de las nuevas prótesis está mejorando mucho la movilidad y la función del hombro. Esa nueva tendencia, de acuerdo a las nuevas prótesis, están disminuyendo la indicación de hacer, por ejemplo, una transferencia tendinosa adicional.
Thank you for the question. It's a very good one. This is, I think, a very important thing for us to discuss. I think that I would tell you that, yes, there are those indications. And here's the thing. We know that if you're over the age of 65 or 70, that the chances of you getting a cuff to repair are very small. The healing of the cuff is compromised after we're 65 or 70, huh? And so to try to get a dead piece of tissue, this is whether it's tensor fascia lata or whether it's in our hands a human dermal allograft or Achilles allograft, it's going to be very difficult to get this to heal. And so if you're 65 or 70 or above, then that is a patient that you have to have a discussion with, because the chances of re-tear in our hands have been too high in that older age group. Now, there are some 75-year-olds who are very young, very healthy, and we try it and it can work, but it's not terribly reliable. So in a very young person who's 75, I might consider trying an SCR, especially if they start out with good motion. That's a reasonable place. If they have arthritis, the big study that we published in North America with myself and Denard and Steve Burkhart showed that arthritis is a big contraindication to doing SCRs. And so in those patients in arthritis, I think that it's very important that we would just go to the reverse shoulder. But here's the problem. If you go to reverse shoulder in someone who is very young, let's say 50, we know that the results, Romeo and others have shown this, are failure at 25% failure at even as early as 3 years. So we don't want to do a reverse in someone who is very young. So that's a patient, I think, where you will try to do something heroic, biologic, or do a hemiarthroplasty, and in addition to the hemiarthroplasty, then do something else, SCR, tendon transfer. The question really becomes, and this is very different depending on as you mentioned, the implant that you use. If you use a medialized implant and you lack external rotation to begin with, you will not get the external rotation back. And I use a lateralized construct, very lateralized construct. We would argue that in a lateralized construct, we can get external rotation back without doing anything else. Now, this is controversial, and my European colleagues would disagree with me on this, but we have the data as well. The challenge is we don't get great strength up here. We can get the patient to get motion in a lateralized construct, but if anybody tells you they can get great strength here, it's not true, at least in my hands. So if I have a patient who has external rotation loss and they need it, and they have Goutallier 4, if they have a Hamada 4 or 5, I'm going to do the reverse. And I'm going to do a tendon transfer in that patient because I need to give them both relief from the arthritis as well as external rotations here. So then the question becomes, when do I do a SCR versus a tendon transfer? And the answer is strictly depending on whether the muscle is alive. You give me good muscle that God gave us, and I'm going to try my best to use that muscle. So if the infraspinatus is Goutallier 0 or 1, then I can make an SCR work in that one, no problem. But Goutallier 4, if the muscle is dead, it doesn't matter if I attach a patch to it, it's not going to be alive. Then if Goutallier 4, we're going to have to move on to the tendon transfer. I hope that answers your question.
Un paciente con pseudoparálisis sin dolor, ¿lo opera?
The question is, in a patient with pseudoparalysis, would I operate on them?
Yeah.
Yes, I think that if I have a patient with true pseudoparalysis that has no motion, I'm assuming you mean anterior superior scape, yeah? in this patient, I think it's very difficult to get any of the things to work that are soft tissue transfers. So if I have an older patient and they have anterior superior scape, that patient I think goes right to reverse, and I think it works very, very well. The problem is what happens to the young patient who has anterior superior scape. This is a problem because the young patient in the reverse is not going to be very good. So what do I do in that patient? That patient, I will work very hard to get the subscap repaired. Most of the time, anterior superior scape, you have a big anterior superior cuff tear, rotator cuff with a subscapularis. So if I have no repairable subscap, I do not only an SCR, but also an ACR, anterior capsular reconstruction, to bring the head down and bring them up. And yes, I will do that.
Doctor Soler, en las lesiones SLAP, cuando son aisladas, nos comentaba que hacía los procesos de reparación primaria dependiendo si era un paciente joven, si era una lesión aislada. ¿Usted tiene algún criterio que lo diferencie cuando está asociado, por ejemplo, a una lesión del manguito rotador? La pregunta va porque cuando nosotros hacemos reparaciones de manguito rotador y durante el proceso de reparación encontramos lesiones SLAP, existen diferentes alternativas de tratamiento en cuanto a hacer una fijación, en cuanto a hacer una tenotomía o hacer una tenodesis. Entonces, si usted tiene un paciente con una patología del manguito rotador y una lesión SLAP, ¿le cambian algún parámetro a hacer ese manejo de la lesión SLAP?
Sí, gracias por esta interesante pregunta. Realmente es un tema que se planteó hace unos años en la literatura, en pacientes de mediana edad que encontrábamos una lesión de SLAP durante una reparación del manguito rotador. Entonces, yo creo que el planteamiento estaba relativamente equivocado. Los últimos recientes estudios demuestran que lesiones de SLAP en pacientes de más de 50 años es más una lesión que se ve en las imágenes radiológicas o lógicamente en resonancia, artroresonancia, o bien en la palpación en el momento de hacer la artroscopia, pero que no tienen absolutamente ningún significado clínico. El problema no está propiamente en la lesión de SLAP, el problema está en el tendón del bíceps. ¿Por qué? Porque si la rotura del manguito rotador afecta a una de las dos poleas de la entrada de la corredera bicipital, o bien tenemos asociada una tendinosis del tendón del bíceps, entonces le hacemos un triste favor a este tendón si reparamos una lesión o supuesta lesión de SLAP que realmente no es la causa del dolor. La causa del dolor es la tendinosis. Entonces, yo en estos casos, en pacientes de más de 50 años que hay una rotura del manguito rotador, yo personalmente no voy ni a explorar el labrum superior. Lo que sí voy a hacer es introducir mediante el gancho explorador el tendón del bíceps, arrastrarlo desde la corredera al interior de la articulación, porque esto nos permite ver patologías inflamatorias, tendinosis, ocultas a nivel en la porción intraarticular del tendón, pero que se ponen de manifiesto cuando ponemos el tendón visualizado dentro de la articulación, pero en su porción de la corredera. En estos casos sí que hago, o bien, según la edad del paciente, una tenotomía, o en pacientes más jóvenes, una tenodesis que la suele asociar a la reparación del manguito rotador.
Ok, doctor Soler, muchas gracias. Doctor Tokic, muchas gracias por su participación. Tenemos que hacer cambio ya a la marcha comercial. Los esperamos en el siguiente simposio de obra. Muchas gracias.
Gracias a vosotros.
Thank you for having me. Hopefully in person next time, yeah?
Be sure.
We hope. Thank you so much. We are going to the commercial show. Fabio, ¿estás ahí? Sí.
Sí, estoy acá. ¿Qué hubo? ¿Qué ha habido?
Perfecto.
¿Cómo
Creo
vas?
que muy bien. Ahí está Asaf.
Ahí
Asaf,
está,
how are
okay. I don't know who está Asaf. Sí, Asaf.
Estaba todo muy tero, pero salieron.
Sí, vamos, se salió. Teru no lo vi, pero sí. Asaf, hi, how are you?
I'm fine, thank you very much.
Okay, what time is in Israel right now?
It's 1:30 after midnight.
After midnight. Thank you very much for your...
Oh, you should get an award for that.
Yeah. Please.
But Israel was just shut down today for 3 weeks, so we're all at home. It's very easy.
Okay,
I'm sorry.
Cheers for that, okay? And
Thank you so
Fabio,
much.
I think you're muted, my friend. Or maybe I just can't hear you.
Hi, John. How are you? Very nice conference. Very clear, no? Very clear. Thank you.
Just a question. I can use my talk live, right? I don't have to use the one I recorded. That's just for emergency.
If an emergency, yes, but let's run the tape that you did before, because we have we have arranged the time for discussion and the time for you with the tape that you sent it.
Oh, so you use the tape?
Yeah, we're gonna use the tape.
Okay.
It's okay.
Very nice conference. The definition, because we need to talk the same languages, because it's the only way to compare the results. If you have a different definition for the same problem, we haven't compared the results. It's the same way for definition of massive rotator cuff.
I agree.
If you see in the literature, massive rotator cuff is the same for large, medium, massive, irreparable. It's a lot of definition for the same problem. So when you compare the results, the outcomes between a work from Europe and work from the America, it's impossible, because the included criteria is completely different. Are you agree?
I agree. I think this is a problem all over the world. We at the Nice shoulder course this year, we did a symposium on massive cuff tears. We couldn't even get through the first talk because there was so much argument about no, this is pseudoparalysis. No, this is pseudoparalysis. And even Gerber and Boileau and Walsh and all of us, we are in the same boat, saying, wait a minute. And you're exactly right, because if I have a pseudoparalysis and I just have pain and I give you an injection and you can do this, well, then I can do anything and it works. Yeah. If I have pseudoporesis even and I'm here, this I can get you to here. But if you have anterior superior scape and you say, well, I'm going to do a biceps tenotomy on you, it's not going to work.
Yes, I saw it. I saw it.
Tricky, right? Yeah, it's tricky.
John, we just heard Boileau telling us about, and he doesn't understand very well the superior capsular reconstruction.
Yeah.
Why the people do that?
Yeah, I think he understands it. I think he thinks it's garbage. He understands it. He understands it fine.
Of course. He understands perfectly. just he wants to send him messages.
Yeah, it's tricky, right? I think that superior capsular reconstruction is it's a hard one, because I think the way that Tero does it, he was very careful on selection, and this is exactly to Paulo's point. If we say to somebody that they have if you have a large irreparable supraspinatus tear, and you come to my clinic and this is your exam, which is Tero's original paper, his patients didn't have pseudoparalysis. They all had motion. So he did a very nice SCR. You do a very nice SCR on that patient, and guess what? They get their motion back. And it's a good pain relieving operation, so they work. So when you look at that original publication from Tiru, the patients had excellent results because he took care of their pain, right? And it was excellent. But then everybody asked, wait a minute, what happens if you have true pseudoparalysis? And we looked at this as in our study with Burkhardt and Denard and myself and Brady, et cetera. And we found that we weren't very good at getting pseudoparalysis restored, partly because we weren't addressing the subscap in the front, which is, I think, the main culprit with pseudoparalysis. Yeah, you have to get, there's an upper third tear of the subscap too. And so we weren't getting this fixed. Then Burkhardt got angry. Steve got a little upset with us because we were saying it, it's hard to do. So he published on his patients where he reversed true pseudoparalysis, but it's only 9 patients.
10 patients, yes.
10 patients, yeah, that's right, 10 patients. And it's a very select group. So yes, I have had patients with true pseudoparalysis reverse it. In those patients, it's because they have an upper third subscap tear, and I've repaired the subscap tear, then I do the SCR, and you're home.
The key is subscap. The key.
Yes, sir.
Asaf, what do you think? Because it's the same indication for the subacromial balloon. A patient functional and irreparable massive rotator cuff, with pain.
Yeah, well, the end-space balloon is mainly, first of all, I forgot to record on my talk that I have a financial interest in the company. Well, not anymore, I sold it already, but actually was regretful I didn't record that.
So you have a lot of money right now.
I think the in-space balloon is I use it for elderly patients. Patients, I would say, average age is 70-ish, low demand, painful, with at least good passive range of motion. If there's glenohumeral osteoarthritis, it's not for this patient. If you want, the patient is high demand and he wants full functionality, that's not for this patient. So the classic patient would be a 70-ish-year-old woman with good passive motion, sometimes even a painful arch, and then I would use it. My concerns about SCRs is that, at least in some of the studies I've read, the MRIs, at least when you use a dermal graft, the re-tear rate is 50 to 70-ish area. So I think sometimes it's a temporary solution, as the balloon is, because it's a temporary solution and I can do a much faster surgery with the balloon. I think when Miata uses a tensor fascia lata, probably the re-tear rate is lower. But these are my concerns. So I offer it to the patients. I say there's a good chance it will reduce your pain. It's not going to get you a full functional shoulder. If you want a full functional shoulder, you should have a SCR, tendon transfer for a young patient, or reverse total shoulder, which is a good solution. But a lot of my patients don't want the full-blown reverse total shoulder solution. So I do it as a step before. I actually do them today under local anesthesia, fluoroscopy style, like we did in Italy with Dr. Gervasi. So it's a 5-minute procedure. I didn't have time to show that video in the recording, but I can show the video. It's amazing. It's 5 minutes, 1 lateral port. I put it in local anesthesia, and if it works, great. And if not, you move them to the reverse total shoulder. I have patients now 9 years out with good results.
Yeah, my only challenge is when you guys did the in-space, how come you didn't make a permanent version?
Well, practically all the patients who improved retained that improvement. So we have about 80% success rate in improvement. And the ones who were improved retained that improvement. Actually, the original plan was to move to a permanent spacer.
Yeah.
But all the patients who improved, nearly over 90% of them, and he showed that in the American study also, that the balloon biodegrades, but nearly all the patients who were responders continue to be responders 2 years out. I don't know if you know, we just finished the FDA study. 20 centers.
I haven't seen it published yet.
No, it's not published. I'll show you the results today.
John, you lost in my questions, please.
So I think the US study has shown that if you get a patient improved, he retains that improvement 2 years out, and the balloon is way biodegraded by then. So, permanent spaces also have a problem.
May I ask you a question about it, though?
Sure.
My argument would be, and I've not done the in-space except at the beginning of the trial, but if you have a patient who comes in and they have a massive irreparable cuff tear and they do this with pain, and you put the balloon in, I think it's a home run. It's going to work. But the patient I'm wondering about is the patient who you do an injection, they have no pain now, and they still can't move the arm. This is pseudoporesis, and you put the balloon in. Not a candidate, yeah? So I think this gets back to Paulo's point about, is it pain that we're treating or is it functional loss? And I don't know it because I don't have experience with the balloon. This is what I'm trying to learn, is if I have pain and loss of function, is the balloon going to ever help?
Yes.
Or is it only going to help in the setting of pain and function that is compromised by pain?
Well, all the patients in the study, in all our studies, had to fail conservative treatment for 4 to 6 months and repetitive injections. So if the pain is originating from the glenohumeral joint because of osteoarthritis or anything else, or pseudoporesis, for example, you won't get help. But I'm not saying I need a patient doing that. I need a patient passively doing that. And that gives me confirmation it's not the glenohumeral joint. And if a patient can passively do that, that's fine. If a patient is here on his own, I still check him and I either give him a lidocaine test, and if he now can do this, I know, and he failed conservative treatment and he failed 2 or 3 attempts of shots, now I can do a balloon. So I think the balloon takes away the pain for enough time for the shoulder to rehab, because it's a temporary solution to get him out of that phase. And then it biodegrades and goes away, but the shoulder is rehab. You know, the amount of people who have a massive rotator cuff tear and have full range of motion is the majority actually of the people around the world. If we're not talking about patients, but everything shows that 30% of a 70-year-old population have a massive or some kind of a significant tear, but they don't have a problem with the shoulder. So what we do is we transform a symptomatic shoulder into a non-symptomatic, and they stay non-symptomatic for over 2, 3, and I have patients 9, 10 years out, they stay asymptomatic. So this is what the balloon does. But no, you can have a painful shoulder with low functionality and still have good results with the balloon if you don't have limited passive range of motion.
I see. Thank you.
Very good. Very good. Well, right now I'm clear, so we can cut off this block, you know.
we don't have questions or discussion now.
Yeah, well, we've done 25,000 cases, and I think the FDA study is a level 1 study. It was blinded, so the surgeon that followed the patients did not know what they had. So I think it's level 1 study of evidence, which is very compelling in my view. I've not seen a randomized trial blinded with this number of patient cohort.
Asaf, the study is compared subacromial balloon versus debridement?
No, versus repair.
Or partial repair?
Partial repair.
Partial repair.
Okay.
Yes. Yes, everybody.
We wanted to compare to superior capsular construction, but
yes, I think it makes sense because
I wish the FDA did not allow it, because apparently, according to the FDA, superior capsular construction does not exist.
That's true. That's true. You should try to get it paid for.
I just want to remember you that in the bottom of the screen, there is a glove interpretation, and you have to put in English, because I wanna speak in Spanish to do every questions, please.
For sure. And Paulo, just one thing before we go on about the superior capsular reconstruction. We always talk about fixing the patch and then fixing side to side the infra, yeah? And then some of us fix side to side the subscap. But I think this is wrong. When I do an SCR, I fix the remnant of the infra, whatever it is, even if it's back, as long as it's the muscle lives, huh? As long as the muscle is alive, then I put stitches in that and I bring it lateral to where it attaches on the glenoid. So it's not a side-to-side repair. Then whatever the patient has left in their infraspinatus, maybe they have only grade 2 Goutallier. If we do an SCR, we don't ever re-tie that, re-energize that infra. So I would say that every SCR for me now has stitches in the infra, the remnant infra, and then I bring it over and I attach it to the patch so that when they fire their muscle, it still acts as a motor with an extension graft on it. And I think this is something that we have failed to do a very good job of, at least in the US.
Tokish, what do you say about the number of re-tear rates reported now? Is that in your hands the same re-tear rate, or you have a different?
The greater than 50% re-tear rate's my work, so I'm happy to talk about it. We're the ones that published this. So and it yeah, it was a big problem. I don't love the human dermal allograft. I don't think it's the best choice. I think Tiro is right. I think that the autograft is good. I think that there are other autografts. I use now biceps autograft to do this, as a lot of people around the world are doing. Sometimes this is a good choice. And then if I have to use allograft, I prefer to use Achilles allograft. And I do that in patients who don't want the tensor fascia lata. But I think the tensor fascia lata is an excellent graft choice. I do probably 1/3 of mine are now autografts.
So you've stopped using the Arthrex pad?
No, I still use it. But I don't. In that patient who has retained motion, then I think it's fine. But I think the graft is too stretchy. There's too much flimsiness to it, and I think the big advantage of the human dermal or the autograft is that it's not only does it have some biology that may be a little bit better, but it's stiffer. And so when we tie that graft in and the patient fires their muscle, they're pulling on something. The human dermal allograft, it has too much flexibility, too much give. So its stiffness is not stiff enough, I don't think, to help retain that. So in a patient who doesn't have motion, and I need that graft to restore motion and strength, I don't like the human dermal allograft. In somebody who has a massive irreparable cuff tear but can still do this, then I think the SCR with the human dermal allograft is fine.
So I would contest and say that a superior capsular reconstruction that failed mechanically, but the patient is still doing well, is just a very, very expensive hard work of doing an in-space.
Every procedure about the rotator cuff massive, the patients become very well functionally.
It's amazing the cost in US, the dermal allograft. You said $70,000. Around here is like $10,000 surgery. That's it.
Is that with the anchors, with the 6 anchors, or without?
Well, with 6 anchor, you can see $15,000.
Yeah, I think I undercharged for the device for the balloon. Yeah,
you did.
Or for this reason, you need to use the biceps as a superior capsular reconstruction and augmentation.
You taught me this.
Autograft is innervated, irrigated. It's very, very cheap. Arthroscopy, reproducible, because it's very easy. No more than 10 minutes the procedure. So you need to 1 anchor and no more. And the patients, the healing of the biceps is almost more than 80%. Clara Isabel de Campos from Portugal published recently a study. Retear in allograft is almost 75%. It's amazing.
I have a study now in a series comparing my human dermal allografts with a biceps autograft. And I don't know, we only maybe 8 patients so far, but this will be interesting to see.
What do you do? A lot of these patients don't have a biceps when you go in these massive long-standing tears. So what do you do then?
Yeah, you go to graft choice number 2, yeah? So either you use a tensor fascia lata auto if you're going to do that, or you go to the human dermal allograft. It's a good point.
Yes.
Normally I use anterior tibial or peroneus and put it a double row, like Ella Shar showing in the biomechanical study. And for me, it's more easy.
The problem in Europe, a lot of them come to you as a second procedure, about 50% of them. And the first procedure in Europe is usually a tenotomy. So not a tenodesis, so you don't have a biceps in a lot of these massive long-standing cuff tears, especially in revision cases.
Tricky.
Yeah.
Don't you think latissimus or lower trapezius transfer is a very good option in that kind of patient? Could be.
So if you have no muscle, like if your infra is dead and your teres is dead, then I think anything that we do to try to do SCR or anything, I think is futile for strength. So again, sometimes those patients can do this. In that case, not so important. But in the patient who needs strength and has a lag, then I think you have to go to the tendon transfer. I have not found the latissimus to be a good transfer in my hands for restoration of strength and external rotation. They can get it, but in my hands, they just have not been very strong up here. Now, I have not done enough of Bassam's technique, but I have done several of them, and so far the results are pretty promising. They seem to get, at least, especially down here, they get pretty good external rotation. Up here is a little trickier. And so I want to know if they have good strength in this position. He reports that they do, and so that's the question for me. Yeah, is whether they get that strength back. But as you know, if you're going to do the latissimus, I'm sorry, not the latissimus, but the lower trap, you're going to have to put an extension graft on it. And if we put an extension graft on it, then we're going to have the same allograft failure rate that issue that we have already.
Yes,
yeah,
of course. Of course.
This is tricky.
Of
This
course.
is tricky.
You can do it with autograft also.
You can.
You can do it.
Have you heard about the bow
hamstring,
technique? Have you heard about the bow technique Arthrex is promoting? I think with what's his name from UK?
Yeah, Ravenscroft, Matty.
Yeah.
Yeah, so Matt and I have talked about that a lot. You guys know it's just an acromial, subacromial resurfacing to just give a little bit of a permanent balloon, if you will. It's a stolen idea from the Israelis. And I would say that he's very happy with his results in that regard. I'm doing what we call an SCR plus. I'll talk a little bit about it, where I do the SCR. We always throw away half the patch when I use dermal. I take the other half of the patch and I do exactly that. So we published on this now where we double the thickness, because Teru's papers have shown us that the 4mm versus 8mm graft the 8mm graft is better, and the best thickness you can get from the human dermal allograft is about 3.2. So now mine is about 7. I don't know yet the results. We don't have enough follow-up on it.
Yeah, you show us in Cartagena last year. I remember.
Is anybody except Matt doing this technique, the bow? I haven't seen anyone use it except.
I have done it several times in patients. I had one where the graft just fell apart and it got away from me, so I didn't like that one. I think it's, but I've done 2 or 3 others where the patient is very happy. I will say that I'm watching my acromial-humeral distance, and you start out, it's pretty good, and then over time I have seen the acromial-humeral distance with the bar technique get even my SCR pluses, it kind of rides high again and starts squeezing down a little bit. But it's a really good pain reliever.
I would imagine it's a permanent, it's a longer acting, I would say, balloon.
So
my only concern would be breakage.
As a spacer, you know,
I'm sorry?
You're getting right with that answer. They're looking for an spacer.
Yes. Well, you guys have seen Rafi Mirazan's paper where he looked at his failures, and he found that if it failed off the humerus, that it was a terrible result. But if it failed off the glenoid and therefore stayed in as a spacer, they did just as well as the ones that didn't fail. So the people who would argue, I think if you want to stand up and throw stones at the SCR and say, really, all you guys are doing is a very, very expensive spacer, we have not disproved that yet.
I completely agree.
Tomo is here.
I think we're all doing spacing.
Hello, Teru.
So I'm glad to say I promoted the spacing in the subacromial. Whatever people do, however they space it, I don't care. I think the results would be the same no matter what we do spacing wise.
Very welcome, Tomo. Very welcome, Teru.
Hello, Tomo.
It's a pleasure for us to have you here.
Good morning.
What time is it?
Good morning for you.
Oh, now here, 8 a.m.
What time is there?
8 a.m. Yeah, morning.
8 a.m. Ah, okay, morning. Tomo, it has closed the microphone. Okay, can you open it, please? Tomo.
Your micro.
Can you hear me?
Okay, perfect.
Okay,
yes,
right now.
Perfect.
I'm sorry.
Perfect. Oh, it's okay. So I'm going to introduce you guys a little bit, 2-3 minutes, and then we start with the Tomo conference. I hope everything run okay, slow. I hope the internet will be fine. We have some problems, not bad. I hope.
At the start of the conference, everybody close their microphone, okay? Put it on mute, the microphone.
Okay.
The only microphone open is the Fabio, okay?
Okay. So ustedes me comparten la pantalla para yo poder colocar la primera diapositiva.
Fabio, tú vas a hacer si quieres empieza a compartir la pantalla, Fabio.
Ok, perfecto.
Porque son las 6 en punto para darle
ya
entrada.
Comparto. Esa es mi pantalla y la voy a colocar acá. Esa es mi pantalla, esa es mi primera diapositiva. ¿Okay?
Se ve perfecto, se ve perfecto.
Listo. Entonces tú me das por favor la luz verde.
Adelante, Fabio. Son las 6 en punto. Demos inicio a este interesante simposio.
Bueno, buenas tardes para todos. Es un placer nuevamente reanudar nuestro congreso virtual con un tema absolutamente controversial, como son las rupturas masivas, qué tenemos que hacer en las rupturas masivas. Y nada mejor nuestro panel de invitados que nos acompañan en la tarde de hoy. Empecemos por nuestro primer invitado de Japón, Tomoyuki Mochizuki. Es uno de los grandes investigadores y anatomistas que tenemos en nuestro medio ortopédico y nos cambió un poco la manera de pensar con referencia a la inserción del infraespinoso con referencia a su trabajo con Sugaya. Trabaja en Tokio Kita Medical Center y hace cirugía de hombro y rodilla. El no menos reconocido o mucho más conocido que todos, Teru Mihata, profesor asociado de los Osaka Medical College y jefe de cirugía de hombro y codo y del laboratorio de biomecánica allá. Y es quien nos ha puesto a pensar en este nuevo procedimiento, nos ha puesto a golpearnos la cabeza con referencia a la reconstrucción capsular superior. También muy bienvenido a Saf Deckel, el especialista en hombro e inventor del OrthoSpace, balón subacromial, que tanto usamos y que tantas veces nos ha sacado de problemas con un simple procedimiento. Queremos oír de parte de él los pros y los contras y cuáles son los proyectos para más adelante. Nuestro presidente, Paulo Ginás, director del programa de segunda especialidad en rodilla y hombro en la Universidad ICESI de Cali, nuestro actual presidente hasta el 2021 y un abanderado de la utilización del tendón del bíceps como solución de aumento en la reconstrucción capsular superior. Y finalmente, John Tokish, una de las personas con más experiencia en lo que son la reconstrucción capsular superior con matriz dérmica celular. Es el director del programa de Fellowship en Sport Medicine en la Mayo Clinic en Arizona y director médico de los Coyotes de Arizona. Esperamos que ustedes disfruten. Vamos a empezar con nuestra primera conferencia de Tomoyuki. Adelante pues. Dejo de compartir la pantalla.
Thank you very much for having me. I'm Tomo Mochizuki. My topic is anatomy of rotator cuff and capsule. I have nothing to disclose. I'm living in Tokyo and my hospital is located in the northern part of Tokyo. And I worked with Hiro Sugaya in 2007. I worked with Ken Yamaguchi in 2009 in the United States. I hope you know our paper regarding the humeral insertion of the supraspinalis and infraspinalis. More than 10 years have passed since our report. I'm going to explain the content short. This is the super view of the right shoulder. The acromion, we removed the acromion. This is a placoid, and this is a supraspine. In this stage, it is difficult to identify the border between the supraspinatus and the infraspinatus. After removal of the overlying tissues such as fat tissues and the coracular ligament, we identify the anterior margin of the infraspinatus is secreting the posterior part of the supraspinatus. In order to clarify the anterior margin of the infraspinatus, we removed muscle fibers from supraspinatus and the infraspinatus. So we identify the posterior part of supraspinatus is thin and short, and the anterior part of the infraspinatus tendon is thick and long. So we can say that these two tendons are totally different tendon structures. So we remove the infraspinatus along with the anterior margin of the infraspinatus. We identify that it occupied most area of the greater tuberosity. On the other hand, cephalospinatus occupied the anterior margin of the greater tuberosity. Fortunately, Loomis 9 reported almost the same footprint as we reported. He said that infraspinatus occupies the middle facet with an extension of the lateral border of the highest facet. In our paper, we also reported the attachment of the capsule is 4.5 mm on average. It was much larger than we expected. Clark reported in 1992, capsule is deepest layer of rotator cuff and thin continuous seat. Capsule seems functionally significant, but there has been no anatomical study refers to capsule. This is a super view of the coronal section of the left shoulder. We can easily separate between the capsule and tendon. So you can see that the capsule is thin, but the insertion side is almost same size as a tendon. We also reported the footprint of the capsule in 2011. This picture shows a large shoulder after removal of the supraspinatus infraspinatus. You can see the capsule is intact. After removal of the capsule, we identified the capsule occupied a substantial area of the greater tuberosity. At the anterior margin of the greater tuberosity, tendon insertion is 3.5 mm and capsule insertion is 5.6 mm. At the thickness point of the tendon is 8.1 mm. At that site, capsule insertion is thin, 3.5 mm. Between the infraspinatus and teres minor, capsule is thickest insertion, 9.1 mm. It means that at the thinnest point of the capsule, rotator cuff has relatively thick insertions. Where the tendinous insertion was thin, capsule had relatively thick attachment. Capsule and tendon seems to complement each other at the insertions. This is a histological section of normal specimen at the 10 mm posterior from the anterior margin. You can see that this is a border between the tendon and the capsule. Thickness of capsule was the same size as that of tendon. However, capsule was attached to smaller areas than tendon. We also reported granule attachment of the capsule in 2018. We peeled off intercapsule from both granule side and humeral side. The anterior attachment was 5.7 mm. Inferior attachment was 7.7 mm. And the posterior attachment was 6.2 mm. So we can say that they are almost same size on the granule side. On the humeral side, anterior side is 5.1 mm and 10.7 mm. At the inferior side, widest, it means 17.3 mm, and the posterior side is 8.7 mm and 9.1 mm. We also analyzed the thickness of whole capsule using micro-CT. This figure shows the thickness of capsule by colors. It means that red and yellow is thick, and green and blue is thin. So you can see that inferior part of the capsule and attachment of the side of the capsule is thick. And also, superior part of the capsule was relatively thick than the other side. Of course, there are some variation of capsule of thickness shown like these pictures. We sometimes observed laminated lesion delamination during surgery. It was partially reported by Sonavent in 2001, and Tanaka reported it was observed in almost half cases of ARCR. However, pathology of delamination is not clear. We made a histological section of specimen with rotator cuff tear. This picture shows a right shoulder specimen with rotator cuff tear. We cut this specimen along with red line. This picture shows, you can see the delamination here. This is a historical section. You can also recognize the delamination here. So at that time, we were wondering if deep layer is capsule or tendon. When we compared the delamination specimen with normal specimen without rotator cuff tear, you can see that deep layer of the delamination and the capsule of the normal cuff looks similar. So we don't have enough evidence, but we think that deep layer must correspond to or involve the capsule. It is a different story from ASCR, but I'd like to introduce anatomical repair of rotator cuff tear with delamination. We think that deep layer is capsule, so at first we repair the deep layer, pulling from medial to lateral and fixed medial margin of the greater tuberosity. After that, superficial layer is mainly infraspinatus, so we pulling the superficial layer from posterior medial to anterolateral and fix lateral margin of the greater tuberosity. This is our take-home messages. Infraspinatus occupies most area of the greater tuberosity. It means that most of rotator cuff tear can involve infraspinatus. Capsule attaches wider area and complements rotator cuff insertion. It means that deep layer of delamination can involve the capsule, and capsule can play important role in shoulder function. Thank you very much for your attention.
Hi, I'm Teru Mihara, Orthochemical College Japan. My talk is Arthroscopic Supercapsular Reconstruction. Here's my disclosure. We developed a new surgical treatment of supercapsular reconstruction for irreparable cuff tear. We have published many biomechanical and clinical studies since 2012. Here is my recent study of supercapsular reconstruction, JVJS last year. It's a 5-year follow-up study. In this study, we found at 1 year after SCR, SS score significantly improved from 29 to 83, and 5 years after SCR, still improving to 92, and the elevation, similar trend at 1 year after SCR, significantly increased from 85 to 138, and 5 years after SCR, increased more, 151 degree. 10% 3 patients had graft tear in this series. In 27 healed patients, we measured graft thickness at 3 months after ischial 7.5 mm, 1 year after ischial 7.9 mm, 5 years after ischial 7.8 mm. So graft thickness did not change significantly during 5-year follow-up once graft was healed. Now I want to show my current surgical technique of ACCART here. First, to prevent post-operative infection, mostly P. acne or C. acne, we sterilize skin using chlorhexidine gluconate just before surgery, and also we cover the skin completely by using iodine drape. Then we measure defect size in anteroposterior direction and medial lateral direction. This patient anteroposterior direction is 4 cm and medial lateral is 4 cm too. Next, we have to decide graft size based on the defect size. Anteroposterior direction is the same size as defect size. Medial lateral direction, now we recommend 1.5 cm longer than the length from superglenoid to lateral edge of the great tuberosity. So in that patient, 4 cm anterior posterior direction and 4 cm medial lateral direction in defect size. So graft size, we recommend AP 4 cm, medial lateral 5.5 cm, and thickness from my biomechanical study, I recommend the 6 to 8 mm thickness of the graft. For ACCART graft, many types of material now we can use. Autograft or fasciolata, synthetic graft, allograft of dermis, fasciolata, Achilles, any other. And my prefer is autograft fasciolata because clinical results so far excellent. Now I want to show graft making. Having fasciolata, and fasciolata usually attached to intermuscular septum. It's a 2 tendon tissue here. If you include the 2 tendon tissue, you can make a thicker graft around 6 to 8 mm. Then suturing in the middle is many mattress, around 8 or 9 mattress. Very important to make a stiff graft. Stiffness of graft very important to stabilize granite joint. My colleague having fasciolata and making graft. At the same time, I treated the inside of the joint. Subsacral stair we usually repair, and by tendon actually mostly leave it. Only 1 or 2% I do tenodesis, but around 98% or 99% just leave it. But actually after ACCART, no pain in the biceps, even without treating the biceps tendon. For ACCART and arthroscopic cortical repair, I do acroplasty very well. We remove the anterior spur, lateral spur, and medial spur is AC joint, and also spur at the distal end of the clavicle also remove, and the undersurface of the acromion we make a flat. I always remove the ciliary ligament completely and remove the lateral and the anterior spur and the undersurface acromion, make a flat, and remove the AC joint spur, and the surface clavicle remove to make a flat. Next, we insert the suture anchor on the superglenoid. We usually use a Nevisor portal and the anterior portal from the anterior to AC joint. This is 1 o'clock position through the anterior portal, and this is Nevisor portal at the 11 o'clock position. This anchor placement. Next, we insert the 2 suture anchor as a major footprint of the great tuberosity. Usually insert is anterior edge and posterior edge of the defect, and my preferred 3 block and fiber tape. Even massive there, 2 3 block and fiber tape are enough because we can make a very strong fixation. Next, we prepare the graft insertion. First, we insert the 10cc syringe as a corner to the joint. Then all of the fiber tape and fiber wire on the medial footprint of the graft superficie take out outside the body, and we attach to the fasciolator in the matrix fashion. Then take out the syringe, then insert again. So all the fiber tape, fiber wire are outside of the syringe. Then we take out all of the fiber wire on the ground to the outside the body. Then we attach to the fasciolator in the matrix fashion. Using this technique, the lateral and medial sutures can be separated completely. After graft insertion, we fix the graft. First, we knot tying on the glenoid in the matrix fashion. Then next, the speed bridge using fiber tape. And then the medial matrix suturing. And finally, side-to-side suture between the graft and the posterior tendons. This is a movie file of graft insertion and fixation. All of fiber tape, fiber wire attached to the graft outside the body. Then take out the 10cc syringe, then insert the graft very gently. Now almost inserted the graft. Then knot time the glenoid first, and speed bridge and the medial matrix suture and side-side suture. This is a final view of the arthroscopy posterior view. This is the lateral fixation that you can see the posterior side-side suture, and the left side is the on the glenoid. This X-ray and MRI is a patient of the arthroscopic movie file, which I showed. The humeral head superior migrated, and the massive tear is a Hamad grade 3. And just after I show, you can see the big space under the acromion. It's Hamad grade 1. Before surgery, very painful and limited range of motion, but after ACCART, very good range of motion, and he could return to the carpenter. Now I have more than 10 years of experience of ACCART using autograft fasciolator, and we have still good clinical outcome after ACCART. So now I can recommend ACCART using autograft fasciolator for massive root cuff tear. Thank you very much.
Hi, my name is Dr. Dekel. I'm the founder and medical director of Orthospace, which was acquired by Stryker and is now operating the InSpace balloon. I thank you for the opportunity to speak here. The InSpace, it's a balloon. It's a biodegradable spacer that sits between the humeral head and the acromion. It's been around since 2010. We've done about 25,000 patients, mostly in Europe, all reporting the same efficacy profile of about 80% satisfaction of patients in VAS scores and constant scores and functional scores. The crown of the jewel is just out, the 184 patients in the FDA study, randomized level 1 study, which I'll talk about in the future. So as I said, space is a balloon. It sits between the humeral head and the acromion. It's a very simple procedure to do, and it can be done in 5 to 10 minutes of arthroscopy procedure, requiring no special skills. Any regular arthroscopic surgeon can do it quite easily. And what you have to do is identify the right patient, a patient with a massive tear, that Coutelier 3-4 type of material of quality of tendon, which is retracted, and you put the spacer between the humeral head and the acromion. You measure the size from 1 centimeter medial to the glenoid rim to the lateral border of the humeral head to the tuberosity level. I actually do as little as possible debridement and acromioplasty, because I think the balloon finds a space. You insert it through a lateral port, you inflate it to its maximal volume, you deflate it to about 2/3 of its maximum volume, and then you leave it in place and lock it. It spreads in place and acts as a spacer. If you sized it correctly and did not overinflate, it's very stable and stays in place. And once it's in place, it allows the smoothest gliding of the shoulder, rehabbing the shoulder and the muscular that is retained apart from the superinfraspinatus. And once it's biodegraded and the shoulder is stabilized, usually the patients retain that function years after a balloon degradation. So what is a massive tear? It's of course a 2-tendon tear with 5 centimeter retraction and more. If it's repairable, I think you should repair. Partial repair can be done. I hope to show that the US study has shown that we have better results than a partial repair. And if it's non-repairable, I think the in-space or reverse total shoulder is probably the two best solutions. Of course, you can do a supercapsular construction or repair. The re-tear rates are quite high unless you do tensofatty lata supercapsular construction. I think MRIs have shown that the re-tear rate is also quite high. But I have to say that even with high re-tear rates, these patients do quite well, as the in-space is also a biodegradable solution and not a permanent spacer. The reverse total shoulder is a much more reproducible technique and a much more reliable technique, but it has its mortality and morbidity. So some of the older patients prefer a smaller procedure. Tendon transfer, I would say, is for the younger and more aggressive patients, high demand patients. So as I said, it comes in 3 sizes. I won't all the data that gathered in Europe. I'm just trying to show you how much data was gathered. And all the data, as I said, show exactly the same results. It shows about an 80% efficacy rate in all scores and VAS scores with very, very low profile of adverse event. Only one study in Spain has showed a 50% re-surgery rate with lower constant scores as efficacy-wise, but the remaining data has all been very consistent. The primary study was in Slovenia of 20 patients here, 69 average age. We followed them for 5 years, an MRI at 3 years to show that there is no bone systemation or any adverse event from the material that is degradable. Constant scores improved from 30s to 60, high 60, with constant score breakdown even improving in every part of the constant. And what is amazing to show is that at 3 months when it deflates and at 1 year when it totally biodegrades, the patients retained that improvement. This is a classic patient. She's a 74-year-old woman. She's actually now 8-9 years out. She's my patient from Israel, and she was scheduled for a reverse total shoulder, not severe osteoarthritic shoulder with humeral joint, so she had good passive motion, but she's very painful. So we decided to put in the balloon, and she was very happy with the results. Of course, because we have very, very quick rehab, we don't fix anything. There's very little pain in the post-op period, and she can start range of motion very quickly. At 6 weeks, she had very good passive range of motion without pain. At 3-6 months, she had quite good range of motion, but still with a painful arch. And she's now 7-8 years out with full range of motion, and I don't think that you'd probably even get this range of motion with a reverse total shoulder, because sometimes in these procedures you lose range of motion. Her constant score went up from 28, if I remember correctly, to the 78, 80 high. So here your last video would show her at 1 year, and now, as I said, she is 8 years out and still doing well. I haven't seen her in the last year because of the corona, but functionally she is doing quite well. She's actually the mother of an orthopedic surgeon. So this is how the balloon looks like in MRI at 6 weeks. You can see it very clearly in the subacromial space, creating a space effect between the acromion and the humeral head. Understand it's a very simple procedure, as I showed in the animation. But the biggest problem here is the patient selection. You have to select a patient that doesn't have glenular osteoarthritis, that the pain originates from the shoulder, the subacromial space, not from the joint, not from the neck, and it's not a patient that had, another reason or failed 3 surgeries. If you pick the right patients, your rate will be 80%. Otherwise, it will go down. We have done cases with balloon on top of repair. Specifically, this was promoted by Dr. Lafosse. He's done hundreds of cases showing that the pain post-op is much reduced because the balloon protects the repair. And there's a study now that has finalized in Italy that even shows that the re-tear rates are lower. Again, you repair as you would, and you put a balloon. Usually you put a smaller balloon, less inflated, not to cause pressure on the repair. We did a study in Munich showing that balloon on top of repair actually reduces the pressure forces on the repair and actually protects the repair. This is because the pressure between the tuberosity and the acromion when you do abduction is quite high, and the balloon, when it sits on top of the repair, actually protects the repair from these high pressures. This is the study that was done with Professor Muller in Munich, and you see here the high pressures in the tuberosity acromion side that are diminished once you put the spacer on top of the repair, and this is repeated in several cadaver labs. We did the cost analysis study showing that InSpace is very cost efficient, especially because it has such a low adverse event rate. We did another study in Italy with Dr. Gervasi and Dr. Enrico Catero. The results of these studies are quite good. The average age was, again, a range of 70s, and VAS scores went down from 7 to 0.9. Total constant scores went from 28 to 65 at 2 years, and ACEs went up from 24 to 84. And please remember, these patients, we did no arthroscopy, nothing, no debridement. We only put in a spacer under local anesthesia fluoroscopy guidance, and you can also do it ultrasound. And these are the constant scores for this study, which are very repetitive of the other studies. So if I sum data coming from Europe, the amount of cases is 25,000 and over 500 patients in all the studies, and all showing the same efficacy and safety profile of the device. If we switch to United States, we just finalized a USIDE pivotal study. This is a level 1 study in 20 centers, top centers, all patients over 40. Arthroscopic in-space device versus arthroscopic partial repair. With a massive cuff, we proposed to evaluate the safety and effectiveness of the in-space, and the hypothesis was that it was a non-inferiority study compared to a partial repair. In a composite safety and effectiveness. It was a very strict run study. As you know, FDA studies are very, very strict, very hard to run. And all patients had failed conservative treatment for 4 months and had to have a 2-tendon tear with full thickness tear with retraction that is not fully repairable, as seen in MRI. And we followed the patient at 10 days, 6 weeks, 3 months, 6 months, 12 months, and 24, with MRIs at 12 months for all the patients, and some of the patients at 6 weeks, specifically the patients with balloon. We followed all the functional scores, work score, ACEs score, constant score, VAS scores, and quality of life scores. It was a 1-to-1 ratio between the two, and all the study was done in US and Canada. I won't go on over all the data. The average age was 66, and the endpoint showed that 51% of the in-space group were responders, meaning an improvement of at least 10% in the constant score and work scores. and partial repair was 39.8. So actually the in-space was not only non-inferior, it was in most of the scores in the primary composite endpoint of efficacy and safety as compared to the partial repair. We followed those patients for 24 months, and we saw that at 24 months, which was a secondary endpoint, the same statistics showed improvement more in the in-space group compared to the partial repair. No device-related adverse events. In most of the functional scores, the in-space outdid the repair group. And I would say that practically zero of the patients had a device adverse event, and most of the patients at 1 year, I think nobody had a re-surgery at 1 year in both groups, and 3 patients in each group had a second stage surgery, reverse total shoulder actually, because they did not improve. As I said, we're expecting about an 80% satisfaction rate and not 100% in this difficult patient. So I think the study data supported the fact that the in-space is the primary treatment for massive rotator cuff tears and showed very safe and effective profile, which we're just filing to the FDA. If I summarize in 2 words the in-space, it's a 10-minute procedure versus a repair or supercapsular reconstruction or reverse, which is a lot longer, with a very safe profile and very happy patients, and very fast rehab since we don't fix anything and we don't replace a joint. Some of the patients in 2-3 weeks are pain-free with good passive and start active range of motion. And once you rehabilitate the shoulder, even though the balloon is biodegradable, we see very, very good clinical results. Thank you for your time.
Es un honor para mí estar en este importante simposio de lesiones masivas e irreparables del manguito rotador, hablando de nuestra experiencia en la reconstrucción capsular superior y aumentación con el tendón del bíceps. No tengo ningún conflicto de intereses y trataré de definir 3 elementos importantes en esta conferencia: definición de lesión masiva, rupturas en nuestra institución y la técnica de reconstrucción capsular y aumentación con el tendón. Existe una gran confusión en la literatura en relación al término masivo. Si usted define a través de los criterios de Gerber, con la presencia de 2 o más tendones, lesiones más de 1.5 centímetros deberían ser consideradas masivas, ya que este es el espacio ocupado por el tendón del supraespinoso. La otra definición está en relación con el Dr. Cofield, quien habla de rupturas mayores de 5 centímetros. Y como sabemos, el tendón tiene unas propiedades elásticas que hacen que el grado de tracción, la configuración, el tamaño del paciente y la posición quirúrgica no permitan tener criterios estándares. En un intento por estandarización del término masivo, desde hace más de 10 años utilizamos 2 criterios de resonancia magnética. Uno es el Paté y el Boutalier, que tienen un alto grado de confiabilidad interobservador, y el otro es una descripción quirúrgica de la exposición de la tuberosidad mayor una vez la hayamos preparado para nuestra reinserción. En la imagen de la izquierda podemos ver cómo hacemos esta medición una vez tenemos expuesta toda la tuberosidad y podemos medir a través de un probador con láser. De tal forma que tenemos 3 criterios y los pacientes deben cumplir al menos 2 de estos 3 criterios: Boutalier 3 o 4, Paté 2 o 3 y la exposición mayor de 25 milímetros de la tuberosidad mayor. El por qué se producen las lesiones del manguito rotador, sin lugar a dudas, es un efecto multifactorial que incluye la edad, el tamaño y algunos factores externos. Sin embargo, mi percepción es que esto es un problema de tipo evolutivo, en donde pasamos de una posición en 4 a una posición erguida y las estructuras no alcanzaron a tener ese proceso acomodativo. Por consiguiente, quizás el supraespinoso y el tendón del bíceps son los 2 únicos tendones que están entre 2 estructuras óseas. Esto hace inclusive que desde el punto de vista evolutivo se haya creado esta cápsula superior y creo que en el futuro esta cápsula reemplazará toda la parte tendinosa de esta parte superior de la cabeza humeral. En nuestra institución decidimos medirnos cuál era el porcentaje de reruptura en lesiones masivas. Tomamos 90 pacientes y encontramos una cicatrización completa en el 74% de ellos. Sin embargo, cuando medíamos los pacientes de lesión masiva, encontramos una reruptura hasta en el 40% y en pacientes mayores de 60 años, casi que hasta el 50% de nuestras cirugías tenían una reruptura al seguimiento a un año. Así que teníamos 3 escenarios en la consulta, 2 en donde hay pacientes que están clínicamente satisfechos, unos cicatrizados y otros no, y un porcentaje menor al 10% que están clínicamente insatisfechos y con rerupturas. Si uno pone en una bolsa todos estos pacientes, tenemos el 25% de rerupturas, pero hasta el 50% de estas rerupturas en lesiones masivas, lo cual es completamente inaceptable. ¿Qué ha pasado en los últimos 25 años y nosotros hemos mejorado esto? Si usted toma la evidencia del lado derecho está el porcentaje de rerupturas de los centros más representativos y de las personas que mejor trabajan en manguito rotador, podemos ver los mismos cifras de rerupturas desde el año 2000 hasta el año 2020 con nuestra presentación de nuestro trabajo. De tal forma que no podemos seguir haciendo exactamente lo mismo para mejorar los resultados. Hace aproximadamente 10 años venimos trabajando en esta técnica quirúrgica publicada en nuestra revista. Un poco de la técnica, esta es una lesión considerada como masiva. En la parte anterior se puede ver el tendón de la porción larga del bíceps. Preparamos nuestra huella plantar, colocamos un anclaje típicamente de 3 suturas y utilizamos estas para hacer una fijación a la tuberosidad, transponiendo el tendón del bíceps a la parte media de esta tuberosidad mayor. Utilizamos un punto primero abrazando el tendón y una salud para poder hacer una fijación más adecuada. Posteriormente a esto realizamos una tenotomía del bíceps y este paso es extremadamente importante porque biomecánicamente sabemos que debemos tener una tensión adecuada, como se ve en esta imagen, en cuerda de violín, lo que hace que este tendón se convierta en un restrictor muy importante para el ascenso de la cabeza humeral. Una vez hacemos esta transposición, utilizamos la técnica que ustedes prefieran para hacer la reinserción de esta lesión masiva reparable. Y aquí en esta figura final vemos cómo es el aspecto artroscópico de esta reconstrucción capsular con el tendón del bíceps. La pregunta ante por qué utilizar el tendón del bíceps a pesar de ser un tendón inervado, vascular, autólogo de una alta resistencia con una fuerte inserción nativa en la glenoides y con un porcentaje de integración de más del 80%, creo que la pregunta no es por qué el tendón del bíceps, sino por qué no utilizarlo. Aquí 2 imágenes representativas de lo que le comentaba previamente sobre la tensión que debe tener el tendón para que tenga su efecto biomecánico y pueda evitar el ascenso de la cabeza humeral. Si esta técnica funciona o no, hay trabajos biomecánicos. He traído solamente este del grupo de la Universidad de Rochester en Nueva York, del doctor Rami El-Ashar, en donde demuestra cómo el tendón del bíceps, bajo esta premisa, funciona mejor inclusive que la técnica clásica de fascia lata utilizada por el doctor Mijata. Otros trabajos biomecánicos como este de Maxwell Park demuestra cómo se disminuye significativamente la traslación superior sin limitación de los arcos de movilidad, algo que nosotros vemos en nuestros pacientes del día a día. Este trabajo, ya no biomecánico sino clínico, del grupo de Grenobles en Francia, demuestra cómo al comparar 3 técnicas quirúrgicas, una de ellas, la reconstrucción capsular superior con el tendón del bíceps, lograron integración del supraespinoso en más del 91% e integración del infraespinoso en el 100% de sus pacientes. Nosotros comparamos una cohorte retrospectiva desde el 2013 hasta el 2007 de 100 pacientes, en un brazo 50 utilizando el tendón del bíceps y en otro brazo 50 sin la utilización del tendón del bíceps, con grupos muy comparativos y valorando rangos de movilidad, escala de haces y escala visual análogas con la integridad del tendón, con un ultrasonido a los 6, 12 y 24 meses postoperatorio. Medimos abducción, elevación, rotación externa, escala visual análoga y haces. Lo que encontramos es significativamente superior la integración y la cicatrización cuando utilizábamos el tendón del bíceps comparado cuando no lo utilizábamos. De tal forma que teníamos rerupturas que iban del 48% hasta el 14% utilizando este tendón. Las escalas prequirúrgicas son muy comparables en los dos grupos y las escalas posoperatorias a los 2 años son significativamente mejores. E igual sucede con la movilidad, especialmente la abducción, que creo es la que hace más significativa esta reconstrucción capsular superior con el tendón del bíceps. Así que teníamos un porcentaje cercano al 50% de reruptura en lesiones masivas y pacientes mayores y logramos mejorar esto a un 14% con escalas funcionales muy significativas. Si uno revisa todos los trabajos clínicos, quiero significar que la gran mayoría de ellos tienen muy buena evolución con seguimientos que van entre 6 meses y 2 años. Sin embargo, no hay una sola complicación inherente a la utilización del bíceps como una técnica quirúrgica de aumentación o de reconstrucción capsular superior. De tal forma, en conclusión, con el tendón del bíceps podemos hacer una aumentación biológica y una reconstrucción capsular superior. Es costo efectiva, artroscópicamente y reproducible. Es un tendón autólogo, inervado, vascular, con una muy fuerte inserción en la glenoides y claramente ha mejorado nuestros resultados. Tenemos una nueva serie en la utilización de este tendón en pacientes con lesiones no masivas próximos a publicar. Quiero invitarlos al tercer Congreso Internacional ACCART 2021 en junio 16, 17 y 18 en la ciudad de Barranquilla. Muchísimas gracias.
Well, good evening again to all my friends in Colombia. This is JT Tokish from the Mayo Clinic in Arizona, and I've come prepared tonight. If we're going to talk about superior capsular reconstruction, I've armed myself with the necessary bottle of American bourbon, which I hope to share a glass with each of you at some point, either in my travels to Colombia or your travels to America. The bourbon is on me, so I wish we could all be together, and I hope that someday we can be again soon. Thank you again for the opportunity, and I would love to speak with you about my experience with superior capsular reconstruction. This has been a tremendously gratifying surgery for me, but also a very humbling experience. We've had to learn a lot of lessons, and I'm grateful to be able to show and share with you some of the lessons that we have learned over the course of the last 10 years in doing this procedure and learning about it. So back down to business to talk about my experience with superior capsular reconstruction. If you take a look at this patient, she's a 54-year-old female with 3 years of pain and loss of function. You can see she still has some external rotation on her side, but she can't elevate her arm at all. And if you take a look at her MRI scan here, she has Goutellier 4 in both her supra and her infra. She has hypertrophic teres minor, but she has no ability to raise her arm, and this is even without pain. And she's got a high riding head as well. So what do we do with this patient with, in her case, it would be true pseudoparalysis, at least forward elevation pseudoparalysis. Well, we can debride her. We can put a patch on her. We can do a lat transfer. We can do another kind of tendon transfer, or you could say sorry, or you could try a reverse. So what do you do with a massive irreparable cuff tear? And as I mentioned in an earlier talk, there have been a number of strategies and all seem to work in the literature. Option number one is just to debride it and cut the biceps. And our French colleagues, Gilles Walsh and Pascal Boileau, have both studied this. And what they found was that they doubled constant scores in these patients. It was very helpful for pain, but they are very careful to note that this does not solve the pseudoparalytic problem. In fact, when we looked at our results of just cutting the biceps in massive cuff tears, we took all comers, many Hamada 4 and 5. We had a 40% conversion to arthroplasty after tenotomy. So this is not a very good operation if somebody has more than just pain, if they have functional loss. Well, what about the next choice, reverse shoulder? Well, the results are okay. If you take a look at Gerber's original publication in the US, his constant scores went from 29 to 64, and his forward elevation got to 100 degrees. But this is certainly not necessarily a home run in some of these patients, right? So, and then if we take a look at the fact that this patient I showed you, and many of the patients are younger, this patient was 54, let's take a look at reverses in younger patients, right? That if we take a look at this is out of the Rush group, Tony Romeo's group, excellent surgeons. And they looked at clinical outcomes of reverse shoulder arthroplasty in patients that were younger than 60. So many of the patients in my practice and in yours. Now, this is what they found. The ASES, again, doubled, 31 to 64. So a good result, but 64 is still not all that great. And at only 3-year follow-up, the failure rate was already 1 in 4, 25% failure. Romeo called it a limited goals procedure, which is kind of like salvage procedure, right? And this is not exactly what we're looking for. So the enter Teru Mihata, a Japanese surgeon who is very creative, and I watched his original presentation from the audience in the AAOS way back in 2010. And he presented his published his paper on 2013 in superior capsular reconstruction, and this is what he found. He used a tensor fascia lata patch from the and strung it from the glenoid to the greater tuberosity as a check rein and a force couple restorer. And instead of doubling constant scores or bringing your score up to 60 or 65, his ASES scores went from 24 to 93. And he didn't get the arm to here, he got the arm to here. Now, if this data holds up, this is a game changer. This is a miracle in many cases because we don't have a good option, or before this didn't have a good option with regard to this particular clinical problem. He's recently published on his 5-year follow-up in JBJS where they autographed SCR, 30 patients, 90% of them healed. There was no progression to cuff tear arthropathy. Now 3 failed, and in the patients that did fail, they all progressed. And their 5-year results were even better than their 1-year results. So the ACS scores in those that healed stayed at 90, above 90, and they didn't do very well when they didn't heal, so they dropped down to about 73. So the take-home message is that SCR, at least autographed SCR in Mihata's hands, have excellent results if you can get the graft to heal, and it seems to be durable at least out to 5 years. Well, does the type of re-tear matter? Those that do tear, and I would call your attention to an excellent study by Rafi Mirazan. So Rafi did a study where he looked at his own SCRs and found that 60% of them retore. 60%. Now, this is done with human dermal allograft, which is what we use in the US most commonly, and I'll get to that in a minute. The allograft ratage, everybody that's published on this has published a high re-tear rate. What Rafi did, which I think is so interesting, is he looked and said, well, I'm going to compare my results in patients who were intact versus those who had what he called a type 2, which was where it was torn off the glenoid. So it was still intact on the tuberosity versus those that tore off the tuberosity. So type 1 intact, type 2 tore off the glenoid, and type 3 tore off the tuberosity. And what he found was that the results were dependent on where the re-tear was. If you tore off the glenoid and remained on the tuberosity, you had an equivalent outcome to if you did not fail. But if you tore off the tuberosity, you had no improvement in your outcomes. I think this is a very important fact for us to pay attention to, because maybe this would suggest that it's not, that maybe this is just a biologic spacer, if you will, going forward. Well, this is what the graft looks like, at least in the US. You can cover very large rotator cuff defects. I cover sometimes 50 millimeters of rotator cuff. I use 3 anchors medially here. I usually use a knotless construct. I usually do some sort of double row repair because this is a dead piece of tissue and we're trying to get it to revascularize. So I want as much healing as I can get. I tie it to the back. I also tie it to the remnant across the top, and I tie it to the front. Now, this is controversial, but I would tell you that tying it across the front may help to prevent anterior superior escape in this regard. Well, we got very interested in this. We were early adopters, so myself and Steve Burkhardt and his brass group, including Pat Denard, published the largest series on in the U.S. back in 2018. These patients were 42 patients with a minimum of 1 year follow-up, and this is what we found. Our results for pain relief were very good. We started at about 6 and we took them down to 2. So not painless, but pretty good in terms of 2 overall. Our ASES scores were good. They were not Mahata's good. They were not 93, but they were 80. 80 is a pretty good result, especially if you consider age-matched controls. Our satisfaction, however, was okay. About 71% of patients were satisfied. Now, we were throwing in everyone that we were doing superior capsular reconstructions on. And so it's a good lesson to take home that we have to be careful. Those that had mainly pain as their complaint with preserved motion, this is a wonderful operation. But so perhaps are many pain relieving operations. What about the patient who has pseudoparalysis? Those patients we weren't as good on, and that 71% satisfaction rate reflects whether the patient was there for pain or functional loss. We did have a number of failures. 4 of them underwent a revision procedure, including 3 reverse shoulder arthroplasties. And from this, we learned that we shouldn't be doing this operation in high-grade Hamada, 3, 4, 5, or certainly 4, 5. And we had a high rate of structural failure, which has been echoed in all the studies that have used allograft, and there may be something different between the two. The lessons from the failure, these are 2 of mine. Number 1, 2 of the failures were in thin grafts. So originally the grafts were 1 millimeter. That doesn't work. So we abandoned that and we go to 3 millimeter grafts. 3 of the failures were in Hamada 3, greater than Hamada 3, so 4, 5. So if you have cuff tear arthropathy already, this is not a good operation in our hands. You need an intact or repairable subscapularis. We were not able to get this operation to work if a subscap is not intact. Now, if an upper third subscap is either repairable or I bring the patch down, it can work at times. So the lessons, most of ours failed off the humeral side, and one wonders if that's mechanical or maybe biologic. We only do them in Hamada 1s and 3s, and if we apply these selection criteria, our failure rate is dropped to less than 15%. But we had to learn to be much more selective in these patients. Well, does the type or thickness of the patch matter? Should you use allograft or autograft, and does the thickness matter? Well, yes, Mahata did a study looking at a difference between an 8 millimeter and a 4 millimeter graft. And what he found was that the 8 millimeter grafts outperform the 4 millimeter grafts. Well, the allografts that we use in the US are never bigger than 4. They're usually like 3 millimeters. And so how do you make up that graft thickness? Maybe the thickness matters. They did a biomechanical cadaveric study comparing the TFL versus dermal allograft. And they found that it was better if you use the TFL, but it was also thicker. So we began thinking about this, and this is how I am currently doing an SCR. This is what I call the SCR plus. So this is a patient that has had an SCR, and you're going to see that in this case, I will add a spacer. I resurface the undersurface of the acromion. So this is an extra procedure with the other half of the dermal allograft. We've taken the acromion, we've burred it down, we've already performed the SCR as you see here, double row repair, and now you can see the patches on the top. And this doubles my effective thickness with the SCR plus to about 8.5 to 9 millimeters. And we're able to show that this holds the head down better than does a traditional simple SCR. So this is how I'm currently doing the procedure. Now, when you apply the lessons learned, Burkhardt has published on a series of his patients with profound pseudoparalysis. So the question is, does it restore or can it reverse pseudoparalysis? My answer to that is it can. It's not reliable. So in my hands, at least, not every patient with pseudoparalysis can get back the motion. But there are patients who certainly do, and Steve published on this recently where he did 10 patients, and 9 of his 10 regained motion. His ASES score went to 89. So, and this is all human dermal allograft. So does it work? Yes, it can. When does it work? Well, for me, if the muscle is alive, I mentioned this last time, there's hope while the muscle lives. So if we're dealing with a massive cuff tear that has decent infraspinatus, Goutallier changed 1 or 2, I think I can restore them even if they're pseudoparalytic. And even if they have anterior superior scape, I will stretch the patch in front and tie it to the subscapularis, and I will incorporate not only the side-to-side stitches in the cuff, but also whatever remnant of the cuff is left over, I incorporate that into my SCR as well. When you do that, I think you can reverse pseudoparalysis as long as the muscle is alive. If the muscle is dead, your chances are no good. That's the patient I move on to a tendon transfer. So in conclusion, with proper selection, I believe this operation remains a game changer. There's fast pain relief, it restores function. Now, structural outcomes are concerning for us, and so we have to be careful about how we do it. We're improving this. So I do a lot of SCR pluses. I do a lot of SCR autografts because I see a lot of revision surgery from outside. I've started incorporating biologics in my practice, and we can talk about that as well. There may be no bridges burned if you do this. If I have to go back and do a reverse shoulder, which I've done many times, a reverse shoulder is a fairly simple operation to do because it's open and it's fairly simple to do. The downsides are this is a very costly procedure. And so you have to be careful. In the US, sometimes this is $70,000 US dollars, $70,000. The patch itself is $10,000. So it can be very, very expensive to do it. And I would say that this is a step forward, but it's not the final step forward. We have much to learn about this operation, about how we apply it, about the technical aspects, and about the biology of this SCR before going forward. But we should continue to refine the patient selection and the technique. And with that, I would say thank you, good luck. Thank you very much for inviting me to Colombia, even though it's only virtually, but I hope to visit you again soon. Thanks again, and have a great.
Okay. Quiero compartir pantalla. ¿Me están oyendo? ¿Aló?
Perfecto.
Ok, perfecto. Teniendo en cuenta todas estas bondades que nos han mostrado en este momento, creo yo que tenemos que hacer un poquito de detenimiento en algo que es importante. Primero compartir la parte del bourbon que nos tienen reservados en Arizona, en Phoenix, por favor. No dejes de tenerlo allí para nosotros, que alguna vez te visitaremos. Segundo, estoy impresionado y me siento honrado.
For sure.
Me siento honrado absolutamente con estas presentaciones y es para mí un placer tratar de llegar un poquito a algunos acuerdos en un momento dado con lo que puede ser este asunto. ¿Ven mi pantalla en este instante?
Sí.
Ok. La verdad es un minuto. Esta paciente, antes de discutir esta paciente, quisiera tener en cuenta, estoy tratando de devolverme, pero no he podido devolver la presentación. Ok, ya. Ok, gracias. Me parece que hay varias cosas que discutir acá. Y lo primero es tamaño y edad. Todas las conferencias son espectaculares y lo que nos han mostrado funcionan perfectamente. Pero Pablo mencionaba algo del tamaño. Indudablemente no existe un acuerdo. Y mencionabas tamaño con 2, 3 tendones, con lo que dice Herbert, con lo que dice Cofield. Sin embargo, lo que tú nos has mostrado no son las mismas clases de rupturas que tenemos, por ejemplo, con las imágenes de Mijata o con las imágenes de Tokish, que son unas cabezas humerales completamente desnudas, absolutamente desnudas. Eso por una parte. Lo otro es la edad. Asaf mencionaba, indudablemente, en pacientes mayores de 70 años, un procedimiento único nos quita dolor muy rápido, bajo costo y absolutamente tiene toda la razón, porque ese paciente muchas veces no quiere ningún tipo de procedimiento. Y Teru nos dice, hombre, esto me funciona con atrofia, sin atrofia y a cualquier edad e incluso con una prótesis. Entonces, voy a empezar preguntándole a Tomo, usted que ha hecho toda esa absoluta disección de cápsula, qué belleza de proyecciones que tiene. Midió la resistencia, la cápsula es igual de resistente al tendón en la parte superior. Cuando uno tiene una ruptura de laminada definitiva, definitivamente es la cápsula lo que tenemos que reparar al reborde medial, o eso es simplemente una parte del tendón. No logré entender mucho si es la misma resistencia o es diferente resistencia. Si es tan amable, Tomo. No sé si Tomo está
Thank you very much for asking. I'm sorry, I can understand that your question by the translator. So you mean the difference of capsule
the difference in the strength.
Or?
The difference in strength between the capsule are the laminated rupture. The slip that you have more articular in the tendon. When you see that, have you measured how different is the capsule versus the tendon, the strength of that?
You mean the strength of the strength of tendon and the capsule strength?
Yes.
I think that I just do the anatomical study, so I don't check the strength of tendon or capsule. But I think that during the surgery, some patients it means capsule, they stretched very well. It means stretched better than the tendon. So I think that the capsule strength is very strong. I hope that I answer your question.
Don't worry, because if you have a very good strength, Tomo, can you put the translator in the bottom of the screen? Can you click on to understand in Spanish, because I'm gonna speak in Spanish. Okay? Did you? You got it?
I can listen your question by the translator. I'm sorry.
There is no translation. Por favor.
Yes, we have.
Yes, we have. Tomo.
Yes. Yeah. Please ask me directly.
Okay. No. in order of that idea, could be the transosseous double row equivalent could be a very good option to repair, because the medial row is going to take the capsule or the laminate tendon, the more articular delaminate tendon, and then the other part of the repair is going to be the tendon itself, and could be a very good repair. But
I think so.
But not all the people do that. So
yeah, that's right.
What's your recommendation for those kind of delamination chairs?
Yeah.
Which is your recommendation?
I think that the large tear without muscle atrophy, like Guttari 2 or 3, I can repair by separate. I can repair that separately. But I think that massive with delamination, we cannot repair separately. In that case, we're going to use. I'm going to use ACCART or reverse or some augmentation.
Some augmentation, like a bicep augmentation, like Dr. Inez said, maybe. No. Okay. I think I'm gonna switch to Asaf. Voy a cambiar para Asaf. Espero que tenga el translator activado. Asaf, primero que todo, felicitaciones por inventarse eso. Ha sacado a muchos cirujanos de problemas, muchos cirujanos de problemas. Indudablemente, es un procedimiento muy sencillo, pero ¿cómo se mantienen los resultados? Dame una explicación que podamos entender, no simplemente con que yo lo coloco y a los 3 o 6 meses el balón se desaparece, pero los resultados al año y a los 2 años se mantienen. ¿Cómo puede ser esto? Por favor, danos una explicación, Asaf.
Yes. First of all, I would dare and ask you, I would explain regardless of the balloon. Out of all the patients coming to your clinic, you give conservative treatment with physiotherapy and injections to all of them before you go to surgery. How many of them improve just on injections and physiotherapy, though they have a massive cuff?
I see.
My estimate is around 50%.
Okay.
So why do they improve and retain that improvement even though you didn't fix a cuff and you didn't do any procedure?
Okay.
Why is a patient that has this, gets 2 injections, physiotherapy, and now he's great?
Now
you didn't fix anything. He still has a massive cuff tear. He does not have a balloon biodegradable. He does not have a superior capsular reconstruction, not a repair, nothing. But still, most of them improve. The fact is, in my view, you have 2 types of shoulders. A compensated shoulder that can do everything, although it has a massive cuff, and a non-compensated shoulder. And the balloon transforms them from a non-compensated to a compensated. And once they are transformed, it's just like rehab, just like the injections.
Okay, okay.
So when I have a tennis player who wants to play tennis, even if he's 70, I would refer him to Mayata because I think his solution is better. But when I have a 70-year-old woman who just wants to do housework, a 10-minute procedure for her to do painless housework with good range of motion, but not high demand, usually is enough.
Déjame, te interrumpo.
So, in my view, it's
Wait.
just an extension of the rehab and conservative treatment in a small procedure. If you follow the full-blown solution, the anatomical solution, you should do either a superior capsular reconstruction, which personally I believe should be done with the tensor fascia lata. The results reiterate show it, or a reverse total shoulder, which is also very predictable.
Okay, okay.
So I think the reason is it imitates how you do rehab and injections. It's not a full-blown procedure.
Thank you. Asaf, terminando contigo, y es esto. Muy buen resultado, pacientes mayores, rupturas gigantescas, pacientes que no quieren una cirugía de un reemplazo articular. ¿Por qué no pensaste o has pensado?
Or a surgeon who cannot do a superior capsular construction or a good, a complicated repair. Sometimes the surgeon is the limitation also.
Yes, yes. Déjame terminar. O paciente, por ejemplo, no has pensado o no pensaron ustedes en hacer un balón que no se degrade tan rápido, que dure más tiempo, si creemos que es el verdadero beneficio simplemente como espaciador. ¿Lo han pensado o lo pensaron?
I have considered it. It took me 10 years to persuade people to do a spacer. And it took me a very long regulatory process to get this now finalized. I definitely think this should be the next stage.
Okay.
But unfortunately, now it's not in my hands, so I'm trying to convince them to continue to a permanent balloon.
Okay,
but
I appreciate short answer because we have.
I definitely think that a permanent spacer like the tensor fascia lata technique is the best way to go. But it's a big procedure, and at least my patients want a small procedure.
Okay.
I think we can all agree that spacing is the way to go. Every one of us has a different spacing solution.
Okay. Ahora, retomando la parte de lo que es la reconstrucción capsular superior. Tenemos muchas maneras de hacerlo. Y aquí nos acaban de mostrar 3 maneras de hacerlo. Uno con matriz térmica, la otra con fascia lata y la otra con una aumentación del bíceps. Y aquí tengo que decir que estoy de acuerdo parcialmente en que se parecen, pero no son iguales. Es decir, los procedimientos que nos ha mostrado Pablo son tremendamente bien ejecutados, supremamente bien editados sus videos, muy buenos resultados. Además, los trabajos que han sido publicados tienen un sustento indudable. Sin embargo, insisto en que es muy diferente esos pacientes que tú mostraste a los pacientes que ha mostrado Teru, a los pacientes que ha mostrado John. Entonces, el punto va a que lo comparable es lo importante. No son procedimientos malos, son todos muy buenos, sino que hay que aplicarlos probablemente al paciente perfecto. Entonces, Pablo, por favor, ¿para ti el paciente perfecto es una cabeza completamente denudada o lo que nos mostraste que sea posible un cierre side to side? Por favor, Pablo.
Esto me da pie para decir dos cosas muy rápidas. La primera es que existe una gran confusión en la literatura en relación al término masivo. Masivo es completamente diferente a irreparable. Nosotros catalogamos irreparabilidad cuando tenemos la incapacidad de llevar el tendón hacia la huella plantar y en estos casos, en la aumentación exclusiva del tendón del bíceps no ha lugar. Uno tiene que pensar en una reconstrucción capsular superior formal o inclusive en un balón subacromial y eso depende de otros factores. Para dar claridad, mi serie es en pacientes masivos que son reparables. Por eso no se muestran esas lesiones tan expuestas. Nosotros queremos mejorar los resultados en lesiones reparables que van en un 50% de ruptura y hemos podido llegar con esta aumentación y reconstrucción capsular superior hasta el 18%. Inaceptable todavía un 18%, pero los pacientes están bien, haces por encima de 70 y la integración del tendón es más del 80% en el seguimiento de 2 años.
Estupendo, estupendos resultados, Pablo. Te pregunto algo y aprovechándote, ¿has necesitado liberar de pronto el intraarticular, extraarticular, esos pacientes para lograr mejor movilidad del tendón o no necesariamente?
No necesariamente, en más de la mitad de mis pacientes no necesito hacer ninguna liberación. Sin embargo, cuando el tendón no lo puedo transponer hacia posterior de una manera libre, hago una liberación con radiofrecuencia del ligamento humeral transverso para que me facilite ese procedimiento. Pero eso es solamente la mitad de mis pacientes. El resto lo puedo hacer sin hacer ninguna liberación anterior.
O sea que yo creo que para la audiencia tiene que quedar muy claro a que estas palabras que dice Pablo que son absolutamente ciertas. Son lesiones masivas por definición, pero son lesiones reparables. Entonces, vamos a la parte de la irreparabilidad, que es lo que nos ha enseñado Teru Mijata y lo que nos ha mostrado también John Tokish. Teru, una pregunta para ti y por supuesto también para John. Ustedes dos son personas que tienen la máxima experiencia en el mundo con cada uno de sus procedimientos y probablemente no tenemos mejor referencia en este instante. Teru, ¿por qué no usar un allograft? ¿Has necesitado de pronto o has intentado hacer lo mismo, pero con un allograft para acortar procedimiento, para la preparación ser diferente o algún otro tejido que sea mucho más fácil manipulable y no hacer ese procedimiento tan bonito que nos has mostrado, que es estupenda disección y estupenda preparación? No sé, Teru, ¿me oíste?
Thank you, Fabio. Yeah,
Okay.
so can you hear me?
Yes, yes.
Okay, so yeah, in Japan, we cannot use allograft. That's why no choice either except the autograft fasciolata. So that's why I use autograft fasciolata. But recently, many paper I saw the from United States with the dermograft SEO, but I read around the 50% or more, sometimes more than 50%. Now Vital is getting less and less. Now recently 2% to 5%. So I think now I have more experience of the dermograft SEO for the clinical. Actually, my feeling is autograft fasciolata SEO and dermograft SEO surgery, I think.
So, Me pareció entenderle, Teru, perdón, pero tal vez no oí muy bien, es que lo ha intentado también con el dermal graft y los resultados son similares o diferentes.
No, in Japan, we cannot use
Yeah, I understand that. In Japan, you don't have the possibility of allograft, but you have intended
Wait a
the
minute.
use the dermal
Translator.
allograft. Bueno, ok. Usted ha intentado usar allograft en otra parte, dermal allograft, alguna vez, ¿no? No es posible intentar. Bueno, ok. Creo que confundí a Teru. Sorry, Teru. John, I'm gonna switch with you. I wanna, usted nos mostró una conferencia donde resume más o menos la experiencia que se ha hecho con la dermis celular de Arthrex. Se supone la más resistente y se supone la que más seguimiento tiene. Pero existen otras dermis celulares antes, en las cuales existían y se habían publicado trabajos, como el Graft Jacket, por ejemplo, como otras marcas, y no entiendo en ese momento, o es que son diferentes, o es que los procedimientos que se estaban haciendo antes con thermal allograft no estaban haciéndose bien, o el concepto no estaba claro. Cuénteme por qué la diferencia de resultados. John, are you
Perfect.
there?
I'm here. Yes, I heard your
Okay.
question very well.
Okay.
Yeah, so the original graft jackets and the original dermal allografts were 1 millimeter thick. 1 millimeter. So this is the reason we felt that the original grafts were not going to work. The graft that we can get now with a human dermal allograft is 3 to 3.2 millimeters thick. It's not going to be able to get thicker than that because you're taking it from human skin, and there's nobody out there with really, really thick back skin. Yeah. So that's the first question. The second is that the processing techniques are different. And there have been a number of studies that have shown that that human dermal allograft does incorporate. Scott Steinman in the Mayo Clinic and Jimmy out of Missouri, University of Missouri, shows that the human dermal allograft does incorporate. But it troubles me because we're asking this in a compromised situation. All of the studies that look at them in animals, everything heals in animals, right? So when we look at basic science and try to justify our grafts, I don't think you can take anything. Anybody that followed the Restore patch, remember the submucosal intestine from the pig? It failed miserably. It looked great in a dog, but it was terrible in a human. So the animal studies, I don't think we can fall back on. I will say this: I do all of the SCR techniques. I learned from Tiro to use his, and there are many times I use it. I use the biceps that Paulo has talked about. I use that one, and I still use human dermal allograft. If you want to know the truth about why most Americans use the human dermal allograft, I'm just going to tell you. Ready? It's because it's easy. It's easy and it's fast, and everything here is driven by the economics of being fast and easy. I'm sorry, but that's true and I'm probably guilty a bit of it too. So because listen, Tiro's graft is excellent, but it's difficult. It's a big incision on the leg. It's not hard technically to do, but it's a big incision. The patients recover fast. I thought they were going to be hurting afterwards. I remember asking Tiro, do you have a lot of graft site morbidity? And he said no. And I did mine, and the first day the guy says, I hate it. But after day 2, 3, 4, they do very well. So he's right. But it's a big incision, and especially my female patients, they don't love that, right? So big incision, you have to take a big wide graft for this, and then it's to put the stitches in and make it look as good as he made it look. This is because he's Japanese and he has the art of the samurai. It's beautiful, his graft. My graft does not look that beautiful. It's a battle to get that graft to look that pretty. Right? And then you got to stick that big graft. He said he was going to put it in gently. You see, when he puts it in, it's not gentle. This is a battle to get that graft is this big and your portal is this big and you have to stuff it in there. I mean, that's the truth. So this is why it's difficult to get wide adoption for that graft, because it's challenging. The little dermal allograft is so pretty, and we make it very nice. We fold it very nice. Whoop, goes right in very fast. But the problem is he's right. Our data shows, and others, that our failure rate may be higher. Now, our original study, we did it, remember, we did it in everybody. Guttalia 3, 4, 5, subscap tears, people that needed reverses. We didn't know when to do it. So we did it in everybody. So I originally didn't trust our original data, because now my failure rate is much, much lower than that in terms of structural failure, because we've really kind of narrowed my indications to it. But it's still higher than I would like it to be. And so I think that's the reason that we get into these troubles.
Gracias por su sincera explicación, John. Y estoy seguro que ese no es el modo de hacerlo los americanos, que quieren todo rápido, fácil, no importa qué coste. Eso es cierto. Nos mostró que estaba utilizando también en la parte superior. Robin Cross tal vez es un escocés o un británico quien empezó a hacer el cubrimiento con ese dermal allograft en la parte acromial. Y usted dice, ha mejorado el resultado, menos dolor, o sea, funciona como espaciador. O sea, volvemos al concepto de Asaf, que un espaciador definitivamente funciona como alivio de dolor. ¿Mejora la función como tal de movimiento en esos pacientes?
Yes, I do. I think that the spacer concept is excellent. I'm not sure it's completely right. I think this actually is something that we don't know the answer to from a basic science standpoint. Is the function of the cuff in total simply to drop the head? If that's correct, then we don't need anything more than the balloon. All we need is Asos balloon in a permanent setting. But it's more than that. It has to be, yeah. So it's not just that. Even you watch his video that I watched this very closely because I think his idea is brilliant. And I want to know the answer to this. If I can just bring the head down, are we done? Because that's the simplest solution. He's right, but we're not. Patients don't often get all the way back up to here. There's more to it. There is a musculotendinous unit, a functional unit that we have to restore if possible. That's why all of us would say, if you can repair the cuff, repair the cuff. If you can't repair the cuff, then we should do our best to restore the muscle, tendon, bone junction by whatever we have to do. This is why Paulo's ideas about these things, I think, are very, very brilliant. Because what he's doing there is he's restoring the muscle, tendon, bone junction. That's the ultimate goal for us, because it still allows external rotation, concavity compression, and head depression. It's more than a spacer. But the spacer for the lower demand patient that can get back to here and has a little bit lower function, for sure, that's a very reasonable thing. But I think ultimately, we as shoulder surgeon, we want a perfect outcome. We want strength in this position, strength up here, good full motion, and pain-free. And I'm not sure that we're there yet in all situations, but I think we're getting closer.
Okay. Quiero mostrar este caso. 3 minutos, por favor. Este caso, y me perdonan que no suprimí los audios, esta paciente se le hizo en hombro izquierdo y hombro derecho la reconstrucción capsular superior, 3 años y medio en el derecho, 3 años en el izquierdo. Y observen la función. El izquierdo está perfecto, asintomático. El derecho está sintomático, doloroso, permanentemente. E imposibilidad. 3 años y medio de evolución en el derecho, que no está tan bien como el izquierdo. Esto es la imagen del hombro derecho. Observen, esto fue el resultado al final de la cirugía. Aparentemente muy bonito para exposición, para conferencias, se ve muy bien. Pero a la paciente funcionalmente no le fue bien, ¿sí? Quiero mostrarles, este es el hombro derecho. Esta es la resonancia actual del hombro derecho, ¿sí? Observen el ascenso que tuvo la cabeza completamente. No solamente el ascenso, sino pues el injerto desapareció quizás en la segunda. Podemos observar acá algún remanente sobre la parte glenoidea, pero se desprendió definitivamente sobre la parte del húmero. y un poco de migración de la cabeza, y tal vez el subescapular no está funcionando bien porque ella se le hizo un refuerzo del subescapular. Observen la radiografía o el corte sagital. O sea, no tenemos nada. El izquierdo que está funcionando bien. Observen el izquierdo. Se aprecia completamente la dermis. Observen la parte de la radiografía centrada completamente en la cabeza y lleno el espacio subacromial, centrada la cabeza también y con un subescapular aceptable. Entonces, vuelve la paciente y me dice, bueno, doctor, ¿y qué hacemos con esto? La pregunta, ¿rehacemos una reconstrucción capsular superior pero con fascia lata o con dermis? ¿O hacemos un reemplazo total reverso? ¿O hacemos una transferencia muscular low trap, un trapecio inferior o un balón subacromial? La paciente tiene 60 años. O un manejo de dolor solamente y hasta cuando resista, y después se hará un reemplazo articular. Quiero cada uno de ustedes que me dé una respuesta lo más pronto o lo más corta posible con alguna pequeña razón. Gracias. Empecemos, John.
Yes, I think the difference in these two shoulders, and you clearly show them here, one of them has a subscap, one of them doesn't. So if you go back and take a look at the imaging, the one that is not doing well does not have a subscap. It has a bald head on the front of that tuberosity on the sagittal images. That's why she failed. So you have to fix something we have to take care of something to do the subscap. So I want to know how aggressive she is. If she's very low demand, etc., and just as pain is a chief complaint, reverse is very reliable. The way that I do a reverse, there is no postoperative restriction. The next day, I let her do anything she wishes. So for me, that would be a great option if she's not really high demand. If she needs to get back to strength and higher demand, I'm going to have to address her subscap. Her subscap won't be repairable by now. So then we'd have to do either an SCR and ACR over the top. That's a big ask. Or we're going to have to do a tendon transfer to fix the subscap in addition to whatever you're going to do in the cuff.
What kind of transfer do you like? ¿Qué transferencia le gusta para el subescapular?
I hate them all. Because I don't think any of them are very reliable, but they're okay. But for me, if I'm going to do this one, again, if the muscle is alive, so I would want to see medial cuts. If I have low-grade Goutallier changes, then for me, this is a perfect indication for anterior capsular reconstruction, which we described a few years ago. I do the same concept that Tiro taught us about the superior, and I just apply it to the front of the glenoid. And then you can bring the subscap back. And I have probably, I'm going to say 30 patients with anterior capsular reconstruction, and my results are actually quite promising.
Dr. Mihata, I wanted your advice.
Yeah, for me, of course, I try to do the fasciolata SCR because she is still 60 years old, and in my experience, reverse shoulder arthroplasty, we cannot get the full range of motion. Actually, some limited, and it's hard to return to the sport in Japan. So that's why I try to do the fasciolata SCR, even fair. Actually, this patient, Hamad grade 3, so for Hamad grade 3, maybe dermal graft is not good material. Maybe stretch out as you show. Actually, even after surgery, the femur head migrated, so that's why ablated and maybe stone. But if you make a very thick fasciolata graft, probably she can get a good range of motion without any shoulder pain. But for the revision case, I recommend a longer immobilization. For primary case, I do the immobilization 4 weeks, but the revision case, now I do 6 weeks.
For subescapular, ¿qué harías para el subescapular?
Yeah, subscapularis, of course, I do repair, yeah, for the reparable, but irreparable cases, yeah, I have found some patients, but I found the high rate of the infection. I don't know why, but maybe the anterior defect, maybe the skin, then directly the joint. That's why the PI infection, I have many. So recently, I do for daily purple subscapularis cases. Now, as John said, the anterior capsular reconstruction. I'm trying. I did a PIC minor transfer before, but not very well. So now I'm switching the anterior capsular transfer.
I see. Gracias.
These are so far.
Paulo, ¿cuál podría ser tu consejo para este paciente?
Creo que es una paciente de 60 años con una lesión fallida. Creo que rehacer una cápsula superior en mis manos no tiene ninguna indicación. Creo que a pesar de tener una MADA 3 o 4, es una paciente funcional por encima de 90 grados, de tal forma que su principal problema es dolor y yo no indicaría en una paciente tan joven un reemplazo reverso. Tampoco tiene una evidencia ni una indicación para una transferencia tendinosa. Yo combinaría en mis manos 4 y 5. Creo que esta paciente necesita rehabilitación y creo que una muy buena forma de darle tiempo a que se rehabilite es poniendo un balón subacromial. Estoy completamente de acuerdo con John en el sentido de que hay que centrar todos nuestros esfuerzos en ese procedimiento quirúrgico en reparar el tendón del subescapular. Mi experiencia es que el tendón del subescapular es extremadamente benigno y uno, a pesar de que haya retracción, puede hacer liberaciones y llevar nuevamente hacia la tuberosidad menor. En conclusión, mi recomendación sería quitar esa fascia, ese aloinjerto que no funcionó, repararía el tendón del subescapular y pondría un balón subacromial.
Ok, muchas gracias, Paulo. ¿No pensarías en transferencia? Para nada.
Pensaría en una transferencia tendinosa si no tengo absolutamente nada que hacer artroscópicamente. Mi experiencia es con el pectoral mayor, no tengo experiencia en subescapular con el latísimo, de tal forma que haría lo que siempre he hecho durante los últimos 20 años, que es utilizar el pectoral mayor.
Ok, gracias. Asaf, ¿cuál es tu opinión? 60 años, fracaso de una reconstrucción capsular superior.
I would probably, I would explain to her that if she's low demand and agrees to be low demand, do a reverse total shoulder. I think that is the most predictable result. Or buy her a ticket to Japan and send her to do a superior capsular reconstruction with the tensor fascia lata. Because in Israel, the patients refuse a tensor fascia lata graft because of the donor site.
The donor side, ok. Ok, thank you. Tomo.
Lo siento, perdón, Fabio, tenemos un simposio que ya empezó y necesitamos terminar.
Ya.
Quisiera que finalizaras, por favor, Fabio, con
Claro
este
que
maravilloso
sí, claro que
evento.
sí. No, no queda sino a ustedes agradecerles. Fue un honor para mí estar al frente de esta discusión. Tratamos de tocar cada punto que ustedes desarrollaron. No me queda sino felicitaciones por tan estupendas conferencias que nos han aportado al Congreso una cantidad de conocimiento y espero que volvamos a tener la oportunidad de hacer un round de discusión de esta naturaleza. Muy amables. Muchas gracias. Que estén muy bien.
Thank you.
Los invitamos a todos, por favor, a pasar a la sala A, en donde está el simposio de Abbott. Bienvenidos.
Ok. Sala A.
Fabio, excelente. Muchas gracias.
No, a ti. Muy amable por la oportunidad.